And the witnesses are ready. I might ask the clerks, is there anybody in the room, either a witness or a member? I can't see the
There is no
room.
one, Mr. Chair.
Very good, thank you. Alors, bonjour et bienvenue à la réunion du comité mixte.
Good afternoon and welcome to the Joint Committee on Medical Assistance in Dying. I'd like to welcome members and witnesses to this meeting. My name is Marc Garneau and I am co-chair of this committee, and I am accompanied by the Honourable Yona Martin, the representative of the Senate. We are continuing our statutory review of the Criminal Code as in relation to medical assistance in dying.
Committee adhere to the following health protocols. I'm not going to name them because by now you're very familiar with them, and they're in effect until the end of Parliament in late June. With just before beginning, a few administrative pieces of information. I'd like to remind the members and witnesses to keep their microphones muted unless recognized by name by the joint chairs. A reminder that all comments should be addressed through the joint chairs, and when speaking, please speak slowly and clearly. Interpretation of this video conference will work like an in-person committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. With that, I would like to welcome our first panel of witnesses today, here to discuss whether to permit medical assistance in dying for mental illness in Canada. On the first panel, we have Mr. John Maher of the Ontario Association for ACT and FACT. We also have two individuals, Dr. Georgia Vrakas and Dr. Ellen Wiebe. Thank you for joining us here today, and we'll begin in the usual fashion. You will each have 5 minutes for an opening statement. I would ask you to respect that 5 minutes so that we can allow as many questions as possible. And we'll start with Mr. Maher. Mr. Maher, you have 5 minutes.
Thank you very much, and thank you for the invitation. The Canadian Mental Health Association, CAMH, the Canadian Association for Suicide Prevention, and my own organization, the OAAF, which is the largest professional association of community-based tertiary mental health care in Canada. To name but a few, all of these organizations have denounced Bill C-7. Anyone who says there is an emerging consensus is grossly misinformed or worse. The Quebec Parliamentary Commission listened to the facts. I'm hoping that you will listen to the facts because what is happening is tragic. I'm a psychiatrist, I'm a medical ethicist. For 20 years, I have worked only with adults who have the most severe and persistent forms of mental illness, in cockroach and bedbug infested rooming houses, and on the streets where our wealthy society forces them to live in poverty. Our sons and daughters treated as social outcasts. MAID activists say everyone must be able to access MAID regardless of crushing poverty, the shocking lack of treatment availability, protracted wait times of years, or having brain diseases where it is impossible to predict irremediability. The rallying cry is autonomy at all costs, but the inescapable cost is people dying who would get better. What number of mistaken guesses is acceptable to you? Death is not an acceptable substitute for good treatment, food, housing, and compassion. You who voted for this law have not understood vulnerability and what it means for your doctor to offer you death over life. And do you seriously believe you can actually prevent abuses by the 100,000 MDs and nurse practitioners in Canada who now have a license to kill? Please read the news. You know Bill C-7 is not consistent with the Supreme Court's stated principle in Carter to preserve life. The ruling explicitly supported people getting help killing themselves only when they could no longer physically do it themselves. Please make a referral to the Supreme Court if you're so sure about how they will rule, because justice and the preservation of life demands it. I'm hearing shock and disbelief from psychiatrist colleagues. When the Ontario Medical Association in 2021 had a survey that asked Ontario psychiatrists clear questions after Bill C7 became law, 91% objected to the law, 7% were uncertain, and only 2% supported what this bill has done. Only 2%. Psychiatrists don't know and can't know who will get better and live decades of good life. Brain diseases are not liver diseases. If guesswork is good enough for you, it's not good enough for psychiatrists who understand the science and respect our duty to abide by a professional standard of care. You have been systematically misled by discriminatory ideology over clinical reality. Passing a law telling psychiatrists to make impossible predictions doesn't magically make it possible. Some of my patients are now refusing effective treatments to make themselves eligible for MAID. They have been susceptible to the perverse lie that it is not suicide. Suicide is always clinically defined as taking the steps to arrange your own death. The Canadian Association of Suicide Prevention has stated that all MAID for mental illness is suicide. The frankly bizarre assertion that suicide is always an impulsive and unplanned act is not rooted in reality. Only 7% of people who attempt suicide in Canada actually die. I'm asking you, what will that percentage become? Likely number one in the world. In the few European countries that at least require standard treatments be tried before euthanasia, there have been steady and significant rises in the overall suicide rates in the last 2 decades, while the rates went down in all the countries around them. Women in particular have much higher suicide rates. The false claim that the Supreme Court accepted without evidence that suicide rates do not go up with MAID is absolutely contradicted by the data. Suicide contagion should scare you. Do you support suicide prevention or not? Telling my patients that you will make it easier for them to die has enraged me. They will doctor shop to find the few psychiatrists who fancy themselves defenders of autonomy at all costs, as already happens in the Benelux countries. And they will die because death was offered over full and purposeful membership in the human community. They will die because of the social suffering that this law enshrines. They will die because of lack of services. They will die because psychiatrists will now have legal permission to give up. They will die because, whether you can see it or not, you have told them they don't matter. You have killed hope in Canada in the places it is needed most.
Thank you very much, Mr. Meyer. I will now go to Dr. Georgia Vrakis. Dr. Vrakis, you have 5 minutes.
Okay, I'll make sure to try to respect that. So, okay, I'm speaking in French. So, bonjour, je m'appelle Georgia Vrakis.
Good afternoon. My name is Georgia Vrakis. I am a psychologist, and I'm also someone who has a mental illness. I'd like to thank you to speak to your Joint Committee on Medical Assistance in Dying. That's first. Secondly, I'd like to strike a position as being against including mental illness as a sole medical condition in asking for medical assistance in dying. This means a lot to me as a professional, a mental health professional, and as someone who's lived with mental illness since I was 23. For 20 years, I thought I had a major depressive disorder. I had several episodes which led to a lot of suffering and work stoppages and suicidal ideation. In 2021, I had my most recent relapse. I was discouraged, disillusioned. Nevertheless, the problem was that I hadn't been properly diagnosed. I was finally diagnosed on May 3rd, 2021 with a bipolar disorder, which is a serious mental disorder and a persistent one. The months before the diagnostic had been particularly painful, and I had thought seriously about suicide. But in the end, I went to emergency. I talked to someone from the Center for the Prevention of Suicide who helped me hold on to life. I didn't want to die. I didn't want to suffer. I just wanted to stop the suffering. That's why this kind of service exists. With promising medication, now I have hope and trust. After 20 years and several relapses, not only am I alive, but I intend to remain alive. This is my personal story, but it's also the story of other people in Canada. More than 20% of the public suffers from a mental illness during their lives. I am not alone. So, mental illness and suicide are problems of public health, and they need a public health response, including mental health as the only grounds in the Act, the Medical Assistance in Dying Act, is a political response to a public health issue. This tends to individualize a societal problem, where mental illness is still taboo, where access to mental health services is very difficult, and where research in psychiatry is underfunded, and funding for promoting mental health and preventing suicide continue to diminish. Our governments haven't invested what we need to improve mental health upstream so that we don't have to deal with someone who's already ill. It's a question of living, not just surviving. In this context, if you give the green light to MAID on the sole grounds of mental illness, you're giving people like me a clear message to opt out if we have mental illness. You're telling us there's no help, that we are disposable. And yet, people are investing in suicide prevention. I know that it's not death, but the end of suffering that people who are suicidal want. They say and repeat, suicide is not an option. How can you reconcile MAID with this attitude, knowing that 90% of people who die through suicide have a mental illness? On a daily basis, we are victims of prejudice and stigma. And how can this attitude, which I feel is a discriminatory one, hold? I think that MAID in the present context is an easy solution in order to deal with a complex problem. What we need is to increase programs that promote mental health and prevent risk factors. We need investing in research in psychiatry, investing in educational programs. The last 20 years have not been easy for me in terms of my mental health. Last year in particular was difficult, and yet I'm still alive. I know that the way forward will be a difficult one, but I'm learning slowly to rebuild myself. Recovery does not mean eliminating all symptoms, nor a return to the pre-diagnosis life. It is a process of rebuilding, which includes mental illness, but which is not limited to it. Rather than stopping us on our path, give us a chance, help us go forward in our recovery and to live in dignity. I'm sorry, Madam, I'm going to have to ask you to end. The Quebec government has heard us clearly and has excluded mental illness from MAID. The question now is, will you listen?
Merci, Dr. Vracas.
Thank you, Dr. Vracas.
To Dr. Helen Wiebe. Dr. Wiebe, you have 5 minutes.
Thank you very much. So I want to tell you a little bit about my experience. I had 30 years as a full-service family doctor, during which I treated a lot of mental health because we did not have good access to psychiatry. And so I have had a lot of experience with treating people with mental illness. I'm also a MAID provider, and for the last 6.5 years have assessed about 750 people for MAID, and I provided about 430. One of these was the one and only person who had made for mental illness as the sole underlying medical condition, which was EF, who, as I'm sure all of you know, was approved by the Superior Court of Alberta to have MAID before I was allowed to provide it. And I also have a lot of experience with our new group of patients who we call Track 2. These are the patients whose natural death is not reasonably foreseeable. And we've been providing for since March of 2021. My own experience is about 40 assessments and 18 provisions. In addition, I work with the Canadian Association of MAID Assessors and Providers and was the lead author for the clinical practice guidelines on assessing patients with dementia and with chronic complex conditions. I am also a MAID researcher and have published a number of articles on MAID in Canada. And one of those, for example, was on suicide versus MAID. And we asked providers, the general public, people who we knew had a great deal of experience with suicide, namely a very vulnerable population, that the kind that Dr. Maher was talking about. And they all were very clear that suicide and MAID were completely different. The differences they talked about, and this is again a wide variety of people, was that MAID meant that people could be with their family. It wasn't illegal. It wasn't secretive. It wasn't put in. I mean, having assistance wasn't illegal, so they didn't have to be secretive, but they could be open and with family. So, for example, EF arrived in Vancouver with 10 family members surrounding her to support her through her last minutes. I want to tell you a little bit more about Track 2 patients, because my research team did a research project on the first 6 months of Track 2 patients and the experience that MAID assessors and providers had. And we got detailed information about 53 Track 2 patient assessments. 67.3% of these, the main challenge was the concurrent mental illness. And this is my personal experience as well. So what I'm saying is that we have already had a lot of experience now at assessing and providing or not providing medical assistance in dying for people who do have concurrent mental illness, not sole mental illness. So I want to tell you that when I assess somebody who has unbearable suffering from an grievous and irremediable condition that includes mental illness, that when I tell them that they are eligible under our law, you should see the smile that comes across their faces, that they've been listened to, that their suffering has been acknowledged in a way that nobody else has really acknowledged, that their suffering is unbearable, that it's unrelenting, that it is, they envision the rest of their lives with more of it. And how do I, as an assessor, say it's irremediable? Because they have had one treatment after another by different psychiatrists, different psych hospitals, and again, I'm extrapolating my patients who have both physical and mental illnesses, but that's my experience, of course, except for that one, which was EF.
Dr. Reeve, I will have to ask you to wrap up, please.
I am done, except to say that I agree with the final report on the expert panel on MAID and mental illness that there should be no new law, that track 2 provisions are working and will work for mental illness as a sole underlying condition.
Thank you very much, Dr. Wiebe. We'll now go to questions, and I'll turn it over to my co-chair, Senator Martin. Over to you.
Thank you, Mr. Garneau. We'll begin with Michael Cooper, and each of the members will have 5 minutes. So, Mr. Cooper.
Thank you, Madam Co-Chair. Dr. Mahar, you stated that in the case of mental illness, it's impossible to determine irremediability. Looking at the definition of irremediable medical condition in the criminal code, that includes serious and incurable illness in which the patient is in an irreversible state of decline. Would you say, in light of that statutory requirement, that could not be satisfied in any case involving mental illness from the standpoint of a MAID assessor?
Certainly, the Quebec legislation that was just tabled got it right when they said that you can't determine whether psychiatric disease is irremediable. You can't. And the paradox here is I'm representing 80 psychiatrists in Ontario who do subspecialist work. We see only the sickest people. So people have been treated for the longest time, suffering terribly. And we're part of a group of 200 subspecialists in Canada. So we do different type of work. We see only the sickest. And the paradox here that a lot of people just don't seem to get, and it's incredibly frustrating for me, is the longer someone has been sick, the easier it becomes to treat them. Because with psychiatric disorders, we have as treatment options literally hundreds of medication combinations. There's no exhausting of treatment possibilities like there is with a terminal cancer where this chemo no longer works. I literally have hundreds of combinations, and when people have tried things, it helps narrow down what will work over time. So it's the work of time. And I'm going to use an analogy here. I worked in pediatric oncology for many years. When a child was diagnosed with leukemia and they had to start a 2-year chemotherapy protocol where they were vomiting and ill for that 2 years, come the 1-year mark, you had kids who didn't want to keep going, right? And what this law is offering people is an opportunity to stop, because the healing is hard and long, but recovery is always possible. I've surveyed my colleagues on this. We've talked about this. We have yet to find a case where treatment and recovery are not possible. The challenge is 70% of all people with mental illness in Canada stop taking their medications, or they don't want to continue treatment because of suffering. So what you're saying is give up before the remedy is provided, give up before the healing is possible. And it's done under this guise of, oh, we've got to relieve their immediate and horrible suffering, poor them. If you did that with dying children, where would you be? Because right now you're offering to do it with dying adults. And these are degenerative diseases, neurodegenerative diseases. The longer you wait, the harder it becomes to treat, but it doesn't mean they're not treatable. And let me give you numbers. My teams in Ontario, we treat the 7,000 sickest. We have 6,000 on our wait lists, waiting up to 5 years. And I would like to know, have any of you had a serious illness where you've had to wait 5 years for treatment? Because this is stigmatization entrenched in our system.
Thank you, Dr. Mahar. And what you're saying essentially is that the expert panel got it backwards in saying that in terms of assessing irremediability, that somehow this could be determined on the basis of treatments that had been provided for over the patient's medical history.
Right. In every other case, we're looking at future treatments that don't work. What the panel said was we look at past treatments that didn't work, but that's helpful, critical information for guiding next steps. And let me quote a line from the panel that I thought was remarkable apropos your question here. This is from the report, the Gupta report. There is limited knowledge about the long-term prognosis for many conditions, and it is difficult, if not impossible, for clinicians to make accurate predictions about the future for an individual patient. They said it in their report. They said it right in their report, and then they're saying they add it's an ethical decision. So unlike every other case of MAID in Canada where you're trying to gauge the clinical reality, whether treatment will work, they say it's an ethical choice. It's in there as well. This is astonishing to me. This report is astonishing in terms of its abrogation of responsibility for we as psychiatrists and clinicians to treat the sickest, most vulnerable. And I literally defy anyone. And Dr. Kuchar, I'm going to single you out. You've said all psychiatrists in Canada who object to MAID for mental illness are selfish and paternalistic. I'm not sure what purpose that comment served, but I defy literally any psychiatrist to say that this particular patient has a remediable illness, because you can't. I have patients who get better after 5 years, after 10 years, and after 15 years. You cannot do it. So it's guesswork. And if you're okay with guesswork, if you're okay with playing the odds, or if your position is, let's respect autonomy at all costs. If someone wants to die, they can die, but call it what it is. It's facilitated suicide. Okay, it's facilitated suicide.
Thank you, Dr. Mayer. And a reminder to our witnesses to address the chair in your response. Thank you. We now have Dr. Fry. You have 5 minutes, Dr. Fry.
Thank you very much. I had a bit of a glitch with my all of the technical stuff, and I wasn't able to hear fully the association, the ACT group. But I am listening to Dr. Ma now answering this particular question, and I wanted to say that you make the point, Dr. Ma, that what the expert panel is saying is that they're looking at what treatment has been done, not what is possible in the future. You then equate that to suggesting that if we look at it from the patient's perspective about what for the patient is intolerable and what for the patient is irremediable, and what they refuse to continue to put up with is not important. It is always about what the physician treating them desires. I don't believe that that is what this is about. I think we heard from Dr. Wiebe about the chronicity of people who have had it and don't want to try anymore. We see that in physical decisions as well, with physical ailments, where people say, I don't want the chemotherapy anymore. I don't want to do this anymore. What makes it different, I'd like to ask you, for a patient who has a mental problem? That is a real problem. It is. We shouldn't put it into a category that says because a patient has a mental problem, they do not have the ability to decide for themselves in many instances. So can you answer me? Is it about what the doctor should be doing, or is it about what the patient requires?
Dr. Mayer.
Certainly. Thank you for the question. And I never said it's about what the doctor wants. I'm answering the legal question. The legal criterion is irremediability. Okay, so let's start with that. If you have a law that says doctors are asked to offer an opinion on irremediability, we can't.
Dr. Ma, I only have 5 minutes to get questions and answers. So I don't really need, I just need you to answer me some simple questions. From what I heard, and I may have misunderstood you, that what you're saying, it's what is possible in the future. But if the patient says, I have gone through enough, I don't want to go through anymore, you think that that is assisting somebody or helping somebody to commit suicide. Obviously, the patient has no say in the matter from what I hear you saying. Do you think the patient has a say?
My daily work involves trying to sustain hope in people who are suffering terribly.
I need a quick answer.
I am answering your question.
No, but you're taking a long time. I only have 5 minutes.
Well, do you want an honest answer?
And I just want a simple answer. A quick and simple answer so I can move on to Dr. Wiebe.
All psychiatrists are passionately committed to the relief of suffering, and we listen to the suffering and are doing our best to relieve it. So
Thank you very much.
How do I serve my patient if they say die instead of heal?
Dr. Wiebe,
Thank you, Dr. Mayer.
Ask you a question.
I'm wondering why you didn't want an answer to my question.
Because I have only 5 minutes, Dr. Ma, and you should not be questioning me about what I need to hear from witnesses that I've heard on today. Dr. Wiebe, you were talking about that you agree with the results of the expert panel. I think you have dealt with many cases, and you have been an assessor for a long time. So tell me, who do you think at the end of the day should be the one who decides what is intolerable, even if it means not accepting any further treatment, because that treatment for them is intolerable?
Only one person, and that's the patient themselves. They are the ones who are suffering, who have suffered, and they are the ones who can choose. And we can't have anybody else making that decision. They are the ones who decide that it is unbearable and that they want a a peaceful and dignified death.
So help me here. Walk me through what you do when you're assessing someone, and do you have to give them every single option that is available to them, and then do you make the decision? Well, how do you go through this? Tell me. Give me a step by step.
Yes. So with cancer, it's relatively easy. There's standard protocols, and they've have to have been offered the treatment. They don't need to have taken it. And for mental illness, it is not so standard because psychotherapy is different from one person to another. And there are, as we heard, many different psychiatric medications and other treatments like electroconvulsive therapy. And so we need to make sure that the patient has been offered a number of different treatments, and that they are reasonable treatments, and that they have tried or seriously considered. The law says seriously considered. And we
Thank
need
you, Dr. Weeb. If you want to just briefly finish up.
Dr. Weeb.
Okay,
just finish
all
your
right.
sentence. Thank you, Chair.
Thank you.
Your sentence. Sorry.
Yeah, so Dr. Weeb, would you complete your sentence, and then we'll go to the next questioner. Thank you.
Just that the patient has to have seriously considered the treatment options.
Okay, thank you very much.
Thank you, Dr.
And
Weeb.
next we have Monsieur Thériault for 5 minutes.
Merci, Madame la coprésidente.
Thank you, Madam Chair, and thank you to the witnesses for their very informative testimony. I'd like to begin with Professor Vrakas. I very much appreciate the fact that people can want and ask for better living conditions and better access to mental health services, whether this be at the university level or in various reports. We all know how we need more services and better access to them. I listened to what you had to say, and I think it's something that should be borne in mind. I also listened to Professor Marr, and I will bear that in mind. However, I'm not a psychiatrist. I am a member of Parliament. And I have an expert panel report that says, and it was already quoted, so I'm going to quote it again, when examining a request for AMAD for people suffering from mental disorders, it must be recognized that thoughts and actions that are to bring about death might be the basis, might be recognized when people request made. So this is not denied. There are mental disorders that lead to a desire to die. And the assessor has to be very careful. And in this situation, they say, in any situation where suicidal ideation is of concern to the clinician, there have to be 3 other perspectives. Bear in mind the person's ability to give informed consent, determine whether suicide prevention interventions should be triggered, and 3, whether other interventions might help the person. Does this give you any comfort? Does this reassure you in the case of people who have mental disorders and have suicidal ideation? Because suicidal ideation isn't the case with all mental disorders. Sometimes people go through a crisis, and then there aren't always cases where you would access to this. What do you think? Well, I don't agree because, as I said earlier, how do you distinguish? When I assess someone, there is no existing tool that would help me to say this person is suicidal and this other person is asking for euthanasia or assisted suicide, which is what medical assistance in dying is. So you have to distinguish between the two. Now, when it comes to mental disorders, there are also cognitive issues. People want to stop suffering, and I know what that means because I went through it myself. I could have asked if it had been available to me 5 years ago. I could very well have asked for MAID, but my diagnosis was incorrect. But the question is, would you have been eligible? From what I read in the report, and I'm not an assessor, but it seems that assessors say that they are capable of distinguishing between a suicidal state, which is reversible, we all agree on that, and something chronic, something persistent, enduring, that's lasted perhaps decades. Yes, with suicide, there are stages. We can assess it. That's what I do. That's what I'm expert in. But when you have to distinguish one kind of suffering from someone else who wants assistance in dying, it's a very, very, it's not clear cut. And there can be problems. That's from a scientific point of view. Thank you.
Next, we will have Mr. McGregor. You have 5 minutes.
Bonjour, Madame la Présidente. Monsieur McGregor s'appelle Monsieur Boulris aujourd'hui.
Yes.
Thank you. Thank you. My name is Mr. Boulris today. Thank you, Chair, and thank you to the witnesses who are here today. Thank you very much, Dr. Rakas, for your honesty. It's very touching. I have a question, and I'd like, if possible, the three of you to answer within the 5 minutes. I have a question that's been really sort of obsessing. Dr. Rakas, you said I did not want to die. I wanted to stop suffering. And it seems to me that many people who have physical illnesses and suffer don't necessarily want to die. They want to stop suffering. My question is how, as a legislator, I can distinguish between the right of someone who has a physical illness and someone who has a mental illness problem. How do I distinguish? I want them both to have the same rights. Dr. Marr said there is no discrimination. But my question is, why should I give rights to someone who has a physical irremediable problem and not give the same rights to someone who has a mental illness? I know it's a very delicate thing, Dr. Rakas, and then Dr. Marr, and then Ms. Wiebe. Well, first of all, when I say I wanted to stop suffering, I wanted to stop suffering. What did I do? I went to emergency. I went to emergency and asked for help. I called suicide prevention, and then my suffering started to diminish, and here I am, appearing before you alive. They could have said, oh, it's irremediable, you know, let's go. But that was not the reality. When someone, that is my answer. Dr. Marr.
And then Dr. Wiebe.
The very short answer to the question is the main difference is we're talking about treatable brain diseases. And so if it's treatable, why are you offering death? And to the second point around suffering, the way Dr. Fry asked the question, she was setting me up to sound like I'm paternalistic or my wishes would supersede the patient's. In fact, the patient comes to me because of suffering. They come to me because they believe I have expertise and knowledge and the ability with my team to relieve that suffering. So why would I offer death instead of doing exactly what they are asking from me in the first place? They have crossed my doorstep seeking help, seeking relief from suffering. And I'm telling you, I can offer it. I'm telling you, teams can offer it. I'm telling you that we only have 1 in 3 Canadians who have access to mental health care in Canada, and you're offering death instead of treatment. So treat everybody, and then let's have this discussion. But to offer death, and you can say, oh, these people had all kinds of treatments. Well, I have patients referred to me all the time from psychiatrists who say they're never going to get better, and they get better because it's subspecialist care. It's subspecialist care. If you have a particular type of tumor, you're not having your family doctor treating it. You're going to a specialist in that type of cancer. It's true in psychiatry as well. You have this false narrative going on here about how it's all equal and all psychiatrists are equal and all diseases are equal. Talk about the treatment-resistant diseases. Talk about the people whose suffering has lasted for a long time, and answer the question, what do they want? They want relief of suffering.
Thank
and I
you,
would
Dr.
tell you
Mayer.
honestly, if I couldn't do it, I would tell you honestly I couldn't do it.
Okay, and Dr. Weep?
I see the physical and the mental illness suffering very similarly. People come to me sometimes and say exactly what you said, Dr. Rackus, that they don't want to die, they want to stop suffering. And so the question is, have they been offered the treatments that might relieve their suffering, and did it work enough for them? So, for example, if I had a subspecialist like you, Dr. Mayer, and I said to my patient, there's a 5-year waiting list for the specialist in your area. Are you willing to continue suffering for the 5 years? And if they said no, then that would be what I would say was irremediable. And the issue around relieving suffering is so similar in many kinds of situations. Most of the suffering that people talk about is not pain, but lack of ability to have a normal life. And that's true of the ones with mental illness as well as the ones with physical illness. And so I don't see a big difference in, have they been offered the right treatment? Can they be offered? We talked about...
Thank you, Dr. Weeb. Yes, so we now have come to this round one's end, so I will turn this back to the co-chair, Mr. Garneau.
Thank you, Senator. We'll now have a round of questions from the senators, and we'll begin with Senator Meji. These will be 3-minute rounds. Sénatrice Meji, vous avez 3 minutes.
Senator Meji, you have 3 minutes. Thank you, Chair. My question is for Dr. Maher, but it could also be answered by Dr. Rackus. I don't know if you were able to thoroughly answer Dr. Rackus, but in order to help you do this, I have a question. When one has a physical illness and a specialist is trying to find drugs or a cocktail of drugs to help them, sometimes people talk about heroic measures. When it comes to mental illness, does that also exist? Does it come to a point where what one is doing is they keep doing this or that to see if the person will get better, trying all different treatments, sometimes experimental? What do you think?
Mr. Mayer?
Dr. Maher?
Do we try things without purpose, or let's see if it works, nothing to lose? The answer is no. I never get to that point. I have standard treatments that work, and it takes a long time to get there. The process of healing is slow. If you were asking me, do I think people should try experimental treatments, to me, that's a matter of subjective choice. I'm not pressuring anyone to do anything. I'm offering standard treatments, and the standard treatments work. And it's an astonishing thing to me. If the treatment isn't available, Dr. Wiebe saying you can't get in to see someone, I'm astonished, wondering, would any of you say, I'm going to die because I can't get the right care? Or are we people in a position of privilege where I'm going to go to the States or I'm going to pay for it somewhere else? Because we're talking, it's actually been said out loud, we'll let people die. We've seen in the news, let people die because they can't get an apartment. Irremediability, on my understanding of the Supreme Court ruling and subsequent legislation, had nothing to do with psychosocial resources. We were talking about diseases. These were medical diseases, brain diseases we're talking about now, where we couldn't medically treat them. So boy, has the barn door been opened wide here if that counts as irremediable. And I'm going to cite this as a specific example of my great fear of the abuses that are going to follow with this legislation, because there's no oversight, there's no requirement that there be prospective judgment of what the doctors and nurse practitioners are doing. And if Dr. Wiebe is going to let someone die because they can't get a treatment that will help them, then I'm frankly just shocked. That is not what this law is about, nor should it be about. And if we as a Canadian society are willing to let people die over apartments, I'm frankly just disgusted. Forgive my passion here, but you're parliamentarians with a duty to preserve life.
Thank you, Dr. Marr. We're now going to go to Senator Kutcher.
Dr. Wiebe, and I just want to let you know that I'm sure all the committee members appreciate the humility of your testimony. Dr. Smith earlier said that he felt that the government of Canada should accept.
Excusez-moi, je m'excuse vraiment là.
Well, we should go.
Excuse me. Yes, I understand. We're having a hard time too.
Have you got your microphone boom down at the right place?
Can we try again? Is this okay?
That's much better. That's
all
much
right,
better.
Thank you so much. For Dr. Wiebe, my questions, I just stated that I'm sure all the members of the committee appreciate the humility of your testimony. Dr. Smith, in his previous testimony, said that he felt that the government of Canada should accept all the recommendations of the expert panel report. Would you agree with that?
No, I accept a lot of it, almost all of it. My concern was with the issues of the provinces and the colleges being responsible for the standards guidelines. There's a huge problem with that. I mean, there's 26 different colleges that are handling the professionals involved, and nurse practitioners and doctors, and they their mandate is that we provide professional and competent care, and that isn't interpreting a criminal law. So they're not. These 26 colleges are not what we need to do this. And the idea of the provinces, or the 13 jurisdictions.
Excuse me, Dr. Wiebe. Would you be able to write that concern down and send it to us so that we would have that concern?
Okay.
Okay. Now, about the couple of things in that report which address some of the concerns that other witnesses have had. One, they issued the idea of having a national framework for case review for educational and quality assurance purposes, a national framework for protective oversight, and improving the federal-made monitoring system. Would you agree with those components of the report? And if you do, how quickly should those be put into place?
Absolutely, and immediately.
So as soon as possible, they would have to be done.
That's right.
There's training of assessment and provider of assessors and providers. Item number 15. Would you agree with that as well? And would you do you have anything to tell our committee about any training programs that are currently being developed?
Thank you. Yes, the Health Canada has partnered with the Canadian Association of MAID Assessors and Providers to set up a national program of education. We have already been doing this, but this will be far more extensive and well done.
And my understanding, and correct me if I'm wrong, was that it's going to be credentialed by the Royal College of Physicians and Surgeons and the College of Family Physicians of Canada. Is that correct?
That's right.
and it includes Indigenous physicians, Indigenous nurses, the Canadian Nursing Association, and multiple other stakeholders in the medical and health providing fields.
Yes, thank you.
Thank you, Senator Kutcher. We'll now go to Senator Delfont. Sénateur Delfont, on ne vous entend pas.
Senator Delfont, we can't hear you.
Peut-être qu'on peut me donner la parole.
Oui.
Do I have the floor? Yes. Thank you, Chair. My question is for Dr. Vrakas. Thank you to the three witnesses, but I only have 3 minutes. Dr. Vrakas, you were talking about a crisis situation, someone who goes to emergency and where they need help right away. But talking about accessibility to MAID, don't you have to make distinctions, because there are safeguards in the law, for example, the time period, and then there are various stages. One is assessed not only by one person, but then by a second assessor. There are also the recommendations proposed by the working group, but the second person has to be a specialist in mental illness. Do you not think that the people who are assessing should have specialized training, and they should work with the attending team? We have a system that's very different from that of reacting to a crisis. It's a system that takes months before someone decides that someone is eligible for MAID. Now, you said that you might have asked for MAID, but nothing says you would have been eligible. Answer: I think it's quite probable that I would have been eligible. I had been suffering for a long time. But you're talking about two different things, because you can be in a crisis situation that doesn't last long. You're in a crisis, you go and get help. But if you're living with a mental illness, suffering it lasts for a long period of time. And over this period of time, you've been trying to get help. First of all, if you have access, and that's if you have access, big F, because there's a problem with access to care. I'm a psychologist and I have to refuse patients. I have no choice. People ask me for my services. There is an absolutely blatant need, but people just don't have access to services. So no matter how you look at this issue, the person is going to have a lot of people over a long period of time, are going to be assessed properly. MAID is offered. You can die. People will help you to die. Death is an option. People say suicide isn't an option, but assisted death is an option. That sends the message that there is no help. There is no hope. So why not do it? They're telling me I can have it. They're offering it. Mentally, socially, it's acceptable. So whatever the protocols, that doesn't change. It becomes mainstream. Thank you. Thank you, Senator.
Senator.
We will now go to Senator Wallen.
Thank you, Chair. My question is for Dr. Wiebe, and you mentioned this, that we make this huge distinction between physical illness and pain and suffering and mental illness and pain and suffering. Can you really speak to that issue, that when it comes to mental illness, it seems that we see it as endlessly fixable and treatment must be relentless and go on and on and on, where we've kind of come to terms on the physical side with saying if you're in intolerable pain, you should be able to have access to MAID. Why do we have that distinction?
why do we have that distinction? That's not my to answer, but I tell you my position here is that chronic conditions are similar, whether they're mental or physical. So, pancreatic cancer isn't necessarily. It has a very strict trajectory, but the chronic conditions that people are suffering with and the treatments are not adequate to make their life worth living, that is similar whether it's physical or mental. The suffering is unbearable. The treatments are either inadequate or unacceptable, and they are people who rationally are able to say, my life is not worth living with this chronic condition, whether it's mental or physical, because it ruins my life. And it's just not good enough for them. And I'm so glad that Canadians have these choices.
If someone was in the stage 4 cancer, we wouldn't argue with them or say, please take one more round of chemo, or please do this, or please do that, if they'd made this choice. But we seem to want to impose that on people with a mental illness.
Yes, and what I'd say is it's more like the case of AB, the court case AB versus Canada, unbearable disability and pain from her inflammatory arthritis, and she said that it was not good enough. Well, we have treatments. You can certainly say arthritis is treatable. It is, but it was unbearable for AB, and that is, the treatments were not good enough for her, and that is exactly what happens with mental illness. There are people for whom the treatments just aren't good enough. They are they're still suffering.
Thank you.
Thank you, Senator Wallen. Senator Martin, you have 3 minutes.
Thank you, Mr. Chair. Dr. Mayer, later we're going to be hearing from Dr. Gupta from the expert panel on MAID for mental illness to discuss the report. Do you have anything that you wish to say about the report or any cautions for our committee?
Thank you. I've known Mona for many years. We're colleagues. She's a smart, wise psychiatrist, but I will say she has information but not knowledge. And she is the first to say out loud that she doesn't work with the sickest people. She has also publicly said that she believes that people should have to have at least 10 years of treatment before you can even start to think about whether someone has irremediable illness. Apropos the myth that Senator Wallen just threw out there, that we're trying to force treatment on anybody, I'm sure that Dr. Gupta would agree we're not forcing treatment on any capable patient. They keep coming, they keep showing up because they want help, they want relief from their suffering. And at the risk of sounding insensitive, no one is keeping them from killing themselves. And I say this with literally a broken heart because of the number of my patients who have carefully and thoughtfully planned their own deaths. So this myth that it's tragic and horrible, and that people keep saying this. Well, it is tragic and horrible in mental illness. We have one study from Switzerland where 40% of the families report having PTSD or depression after supporting a loved one who's dying. So when Dr. Gupta's report brings together plausible evidence, but in the same breath says we can't identify who's irremediable, the key legal criterion we're talking about here, your duty to review, and also says that this is an ethical decision, not a clinical decision. I'm frankly stunned that Dr. Gupta has gone there. And I'm also wondering why 2 people resigned from that panel. I would like to know that story. But what you've got is you have a number of very sensitive, thoughtful statements, but not a single safeguard. In the Benelux countries, you at least have to have tried standard treatment before you get euthanasia. In Canada, we won't even require standard treatments. It's astonishing. Thank you.
I was going to ask Dr. Vrakis, actually, if you have, are there any safeguards that could make MAID for mental illness safe?
Rapidement, s'il vous plaît.
Quickly, please. Well, yes.
There are, in my opinion, right now, based on evidence, I mean, studies, research, there is no acceptable safeguard that will make MAID for mental illness safe.
Thank you.
Thank you very much. And that concludes our first panel. I would like to thank on behalf of the committee, Mr. Maher, Dr. Georgia Vracas et aussi le docteur.
And also Helen Weeb.
Pour vos témoignages aujourd'hui. Merci d'avoir répondu à nos questions.
Thank you for your testimony. Thank you for having answered questions on this very complicated issue, and I dare say emotional issue. It's very appreciated. We will now suspend for a few minutes and then go to our next group of witnesses. Thank you, everyone.
To discuss whether to permit medical assistance in dying from mental illnesses or disorders in Canada. So first, there's Dr. Alison Freeland, Chair of the Board of the Directors, Co-Chair of the MAID Working Group from the Canadian Psychiatric Association, and as individuals, Mr. Mark Signor and Dr. Tyler Black. So thank you for joining us today for the second panel, and we'll begin with opening remarks by Mr. Signor, followed by Dr. Freeland and Dr. Black. Mr. Signor, you have the floor for 5 minutes.
Thank you very much. Good afternoon, committee members. It's an honor to be with you today. My name is Mark Signor. I'm an associate professor of psychiatry at the University of Toronto and a psychiatrist at Sunnybrook Health Sciences Center who specializes in the treatment of adults with complex mood and anxiety disorders. My research is focused on suicide prevention. I'm a former vice president of the board of the Canadian Association for Suicide Prevention, lead author on the Canadian Guidelines for Responsible Media Reporting about Suicide, a steering group member of the International COVID-19 Suicide Prevention Research Collaboration, and I was recently asked to coordinate the International Association for Suicide Prevention's efforts to create a regional suicide prevention network across the 35 countries in the Americas. I should note that I am not involved in MAID assessment or provision. I am also not a conscientious objector to MAID. To be transparent, my professional agendas, both in general and in these deliberations, are to do my best to help contribute to a Canadian society with fewer suicides and to protect psychiatry as an evidence-based science. Given that I only have a few minutes, I will focus my remarks on what ought to be the overriding issue in your deliberations. As highlighted in the expert panel report, I and some of my colleagues have argued that, like any other medical procedure, physician-assisted death for sole mental illness should be permitted only if there is evidence that the benefits outweigh the harms. In their recently tabled report, the expert panel noted that they, quote, considered this possibility but did not arrive at this conclusion, end quote. The imperative to do no harm has been a foundational principle of medicine for thousands of years and underpins the modern principles of evidence-based medicine, which call for us to undertake scientific evaluation of the benefits and harms of our treatments to determine whether delivering them is ethical. If as a country we're going to reject these ideas, first, we should be aware that we're doing so, and second, we ought to have a compelling reason. In short, we are missing essentially all of the necessary scientific evidence to evaluate the safety of physician-assisted death for mental illness. If I had more time, I could list many examples, but let me focus on the fact that there is absolutely no research on the reliability of physician predictions of irremediability of illness or suffering in psychiatric conditions. To my knowledge, there is not a single study. Advocates for the practice are suggesting that we have safeguards. That is because the practice carries many inherent dangers. This is the entire reason for safeguards. We do not propose safeguards for practices that are already safe. But the degree to which any proposed safeguards actually fix that problem is entirely unquantified. No one has provided you with those numbers because there has been absolutely no research and they don't exist. As a result, if this goes forward, MAID assessors will have no idea how often they are wrong when they make a determination of eligibility in the context of physician-assisted death for sole mental illness. They could be making an error 2% of the time or 95% of the time. That information should be at the forefront of this discussion, and yet it is absent altogether. There are many other examples of evidence about serious harms that are simply missing, such as rigorous study of the impact on suicide and its prevention. Nothing in life or in medicine is certain. All of our treatments carry potential benefits and potential harms. In medicine, we deal in probabilities. Doctors help patients make decisions in cancer treatment, for example, by sharing that a chemotherapy might result in survival 90% of the time or only 10% of the time. In neither case do we know the outcome for certain, but those numbers are crucial in helping patients make informed decisions. In physician-assisted death for sole mental illness, we have no numbers at all. Neither we nor our patients would have any idea how often our judgments of irremediability are simply wrong. This is completely different from MAID applied for end-of-life situations or for progressive and incurable neurological illnesses, where clinical prediction of irremediability is based in evidence. In the context of physician-assisted death for sole mental illness, life or death decisions will be made based on hunches and guesswork that could be wildly inaccurate. The uncertainties and potential for mistakes in mental illness are enormous, and therefore the ethical imperative to study harms in advance of legislation is accordingly immense. What is so disconcerting here is that we could conduct the necessary studies. We demand evidence on benefits and harms before legalizing natural health products, new medicines, vaccines. Why skip that step in such a profound deliberation as the one you're engaged in now? I would argue that we owe it to our fellow Canadians with mental illness to have the necessary scientific information in hand before making such a consequential decision. And thank you, and wishing health and well-being to all during the pandemic.
Thank you very much, Mr. Senior. Next, we will have Dr. Freeland for 5 minutes, Doctor.
Thank you for the opportunity to be here today. My name is Alison Freeland. I am a psychiatrist. I am here in my capacity as chair of the board of directors of the Canadian Psychiatric Association and co-chair of the CPA's MAID working group. Today, I will focus my remarks on medical assistance in dying as it pertains to requests on the sole basis of a mental disorder to supplement the CPA's brief that was submitted to this committee a few weeks ago. The CPA has not taken a position on whether MAID should be available where mental illness is the sole underlying medical condition. However, we do believe that any new legislation must protect the rights and choices of all vulnerable Canadians without unduly stigmatizing and discriminating against those with mental disorders where eligibility requirements are determined to be met. In considering safeguards, the CPA discussion paper looked at the issue of capacity. A mental disorder does not in and of itself imply incapacity in any domain of decision-making, but when active, various forms of mental illness can impair decision-making incapacity. Psychiatrists have specialized training and expertise in the assessment, diagnosis, and treatment of mental illnesses, including the assessment of decisional capacity, as well as the durability, stability, and coherence of a person's expressed will and preferences. Psychiatrists are well versed in taking into consideration any external constraints or internal psychopathology that may impact these issues. Inequities of service provision and funding are an issue for all types of conditions, and this is an area that is particularly problematic for people living with mental illness. Such inequities are further exacerbated for people who live in rural or remote areas. Whether the illness is physical, mental, or a combination of both, equitable and timely access to evidence-based, culturally appropriate clinical services is a first and essential safeguard to ensure that people do not request MAID due to lack of available treatments, supports, or services. In the context of mental disorders, there is no generally agreed definition of incurability. And within the field of psychiatry, there are some who do not accept that any mental disorder is incurable and will argue there is always another treatment to be attempted. Resolution of this issue requires a pragmatic approach that balances clinical expertise and assessment of incurability with the patient's perspective and experience of their illness. Socioeconomic determinants of health, which play a key role in each person's experience of suffering and adaptability to mental illness, are important to consider. If a patient refuses recommended treatment for their disorder without good reason, weighing both the potential benefits and burdens, they are unlikely to have met the eligibility criterion for incurable. Vulnerability is not limited to those with mental illnesses. Many people with non-psychiatric illnesses are also vulnerable because of psychosocial circumstances such as isolation or poverty, cognitive distortions, and demoralization due to failed treatment attempts or difficulty in adjusting to life with their illness. The trajectory of physical illness can be as unpredictable as that of mental illness. Loss of hope can occur, as can spontaneous remission. Predicting treatment outcomes is as much a challenge for psychiatry as for the rest of medicine. Both acute and chronic suicidal ideation must be considered and evaluated to make a best determination as to whether the patient's wish to end their suffering represents a realistic appraisal of their situation rather than a potentially treatable symptom of their mental illness. A request for MAID should be considered and sustained and not the result of a transient or impulsive wish. This is particularly important for persons with non-terminal conditions, such as a mental disorder, where illness may be more episodic in nature. Therefore, separate from any MAID eligibility assessments, it is essential that at least one independent psychiatrist completes a comprehensive clinical assessment to validate whether the patient has received an accurate diagnosis and if they have had evidence to evidence-based mental health assessment, treatment, and supports for an adequate period of time based on generally accepted standards of care. Thank you very much, and I'm happy to try and answer your questions.
Thank you, Dr. Freeland. Sorry, Joint Clerks, I don't see Dr. Black. Am I correct?
I am here.
He's there, Senator. He's just on the screen now.
I see. Sorry. Thank you very much. So, Dr. Black, you have 5 minutes.
Thank you for the opportunity to provide my perspective. I'm a physician with 14 years of tertiary experience in emergency psychiatry involving suicidality, and I'm a researcher, teacher, and expert in suicide and suicidology. It's really important to note that what most people think of as suicide is far different than most experience have made. I've submitted a brief regarding many of the myths comparing suicide to MAID, and I trust that it's been helpful to the committee. I'd like to draw special attention to 3 of the points that I made. First, motivations in MAID and suicide are rarely the same. In suicide, it's very rare to have a combination of fatalistic motivation, which is a controlled response to a perceived stress, an agreed upon lack of remedy, and a rational calculation of the likelihood of change. Whereas in MAID, this is almost always the case. In the literature, psychiatrists generally agree with the patient's unbearable suffering and futility of treatment in psychiatric MAID cases in the countries this has been studied. Second, the wish to die is not indicative of a mental illness. While depression does include suicidality as one of its 9 criteria, the presence of a serious mental health diagnosis is absent in 40 to 50% of all who die by suicide. And many who experience suicidal thinking do not have a diagnosable mental illness and the vast majority do not die by suicide. Third, capacity assessments are a core part of psychiatric training. This is probably the most achievable and least controversial aspect of these discussions, and not an area of significant controversy in psychiatry. So to the larger complex question regarding psychiatric MAID, I'm comforted by an approach that helps me in my clinical life. See, most of my patients are sent to me as a tertiary psychiatrist when other psychiatrists and doctors are seeking care and expertise for a complicated case. Where other physicians who have primary presentations coming or follow guidelines or algorithms, I rarely have an algorithm to follow. In fact, the book of algorithms for my line of work would be minuscule. Rarely do I ever have a perfect answer. For this, I both teach and practice science-based medicine and principle-guided medicine. For science-based medicine, we use the best evidence we have at the time, we apply plausibility and expertise, and recognize the importance of updating our information as new excellent information comes to light. In this regard, there's decades of experience of MAID in some countries and some with psychiatric MAID, and it suggests that it's well practiced, well accepted, and represents only a small fraction of all MAID deaths, 1 to 2%. Given the number of people with suicidal thinking, there is simply no credible foundation for the fear that allowing MAID for psychiatric conditions would create a flood of deaths in Canada. One study estimated suicidal thinking as an 8% lifetime risk for adults in the Netherlands, yet 65 or 0.0004% of adults in the Netherlands have died of MAID in any given year due to psychiatric reasons. Adding the procedures that should be in place for MAID, the plausibility of a hasty, poorly thought out conclusion regarding MAID is drastically reduced. I've also submitted evidence regarding a review of studies of psychiatric MAID in various countries to the committee. For principle-guided medicine, one uses a set of principles to dictate decision-making. There are many principles that I consider when it comes to psychiatric MAID. First, we must respect the autonomy of our patients, especially when we have determined that they have capacity to make decisions for themselves. Second, we must be cognizant of systemic racism, systemic ableism, and lack of access to mental health care in Canada. It should never be that someone chooses MAID due to a system that inflicts racism or ableism on that person or limits their ability to access quality mental health care. Third, we must not discriminate against people with mental illnesses, nor discriminate against psychological suffering. Fourth, not all conditions respond to treatment. No treatment in psychiatry has a 100% cure rate, and psychiatry has been loathsomely slow compared to other specialties to the medical notion that some people do not, for a variety of reasons known and unknown, respond positively to treatment. For some, treatment is a miserable experience with no benefits. Fifth, psychiatry has a long legacy of paternalism, and decisions must be centered in a place where the expertise of physicians and those with lived experience overlaps. Finally, only a physician's professional opinions, not their personal beliefs, should exert influence on a patient in their healthcare decision-making. I can imagine a system in Canada that honors the best science and principles we have regarding this issue, and for that reason, I'm cautiously but generally supportive. Thank you.
Thank you, Dr. Black. Thank you to all of our witnesses for your testimonies today. That will be very helpful to our committee. So we'll begin our first round with Mr. Cooper. You have the floor for 5 minutes. Mr. Cooper, your sound is not working. Try again. We seem to have a technical issue with Mr. Cooper's headset at the moment. Perhaps I will, I think it's working now. Mr. Cooper, will it try again?
Can you hear me now?
Yes.
Okay, very good. Dr. Sonora, in your testimony, you said that what is lacking is literally all necessary scientific evidence to establish that MAID can be carried out safely in the case of sole mental illness. You focused in specifically on the lack of study around predicting irremediability, but you did go on to say that you could cite other examples of evidence that is missing. So I'd invite you to take this time to do so.
Oh, thank you very much. I mean, I think there are a few key things. The first is that the legislation doesn't only talk about incurable illness, but incurable and intolerable suffering. And the idea of incurable and intolerable suffering doesn't actually have a scientific definition. There was an article in the Canadian Medical Association Journal just a month ago in which there were calls for a scientific definition for that, which would really be a precursor of being able to study it. So, just it's important, I think, to alert the committee that the concept that we're trying to treat doesn't even have a scientific definition, and that's part of the reason that there have been no studies of it. I think there's a whole host of other things that we need to look into beyond not only the irremediability of psychiatric suffering, but also the not only the irremediability of psychiatric disorders, but also the irremediability of psychiatric suffering. While I agree with the other witnesses that there are psychiatric illnesses in which we know that we can't cure the underlying illness, that's actually somewhat different from the idea of whether we can provide a treatment that may be able to alleviate the suffering that corresponds to that illness. And that's something that, to my knowledge, has never been the focus of a single psychiatric study or any kind of study. The large rest of studies that would be necessary are those related to suicide and suicide prevention. So, we just heard, for example, correctly that there's this question about whether MAID is suicide and not. Some people say it's exactly the same thing. Some people say it's totally different. The reality is probably there's something in between. And obviously, in the case of mental illness, we have to be concerned that there may be substantial overlap. And so trying to quantify the degree to which that overlap exists, the degree to which messaging, I'll just say that my research mainly focuses these days on public messaging. And what we find is that when you message across society that when you're having difficulty and you're struggling with mental illness, and you can go seek treatment and you can get help, you see fewer suicides across the population. And when you see media reporting about the idea that people, when they're in difficulty in life, will take their own life, you see an increase in suicides. And so the degree to which that media reporting and this sort of cultural change that we have may have an influence is something worth studying. So is the impact on the physician-patient relationship and how people view psychiatry. And then I would say that the last thing that probably would be worth studying is an economic analysis of whether there are perverse disincentives, because of course, what you would want if this goes forward is that any money that's saved by, through MAID is then funneled back into the mental health system. But there is the possibility, of course, that there's a perverse disincentive to invest, because of course, if you don't invest, then more people have what appears to be irremediable illness, and then they die through MAID, and then our healthcare system just gets worse, which would be, I think we can all agree, a complete disaster. All of that research would be helpful to know before going forward.
Yeah, well, thank you very much. And I presume that absent being able to establish irremediability, talking about safeguards is really putting the cart before the horse, that if you can't establish irremediability, you really can't go forward. Certainly from the standpoint of the legislation, but even putting aside the statutory requirement from a safety standpoint.
Well, I think that's correct. I mean, if you think about it just logically, if someone says, can this plane fly? We have a dangerous plane. We know that it crashes. Can we get it safely from point A to point B? You could get a group of people to say, well, we should put into place a whole bunch of safeguards. But without actually testing those safeguards, I wouldn't want to get on the plane.
That's right. And perhaps if you could just explain what full disclosure for informed consent for MAID in the case of sole mental illness would look like.
I think here's the difficulty, because one could construct a study where you take all of those people who might be eligible for MAID for mental illness and provide them with really excellent care. Provide them with whatever they might need: psychotherapy, adequate pharmacotherapy, a nutritional program, exercise, access to neurostimulation, other psychosocial interventions that might help. And you could look and see what proportion of those patients actually change from appearing irremediable to remediable. And I think many of us are concerned that it's probably a very large proportion of them. And so the concern there is that psychiatrists don't know that because we don't have the research. There's no evidence for it. So you could have a patient and a psychiatrist sit together and earnestly decide there's nothing that can be done. This case is irremediable, and both have that entirely wrong. And then to have that person end their life. And as a practitioner, clinician, psychiatrist, the idea that we might go forward with that without informing patients that that is a possibility is a problem. And at the moment, oh, sure.
Thank you very much. Next, we'll have Mr. Maloney. You have 5 minutes.
Thanks, Madam Co-Chair. Thanks to all three witnesses. Your presentations were excellent and level presented based on some previous panels we've had, most recently an hour ago. Dr. Senior, I'd like to start with you, if you don't mind. You started, or at one point you said, you're trying to protect psychiatry as evidence-based science, which I respect and I thank you for. Have you ever rendered an expert opinion in a legal matter before?
Yes, in the Truchon hearings.
Okay, right. Okay, now it seems to me, regardless of what side of this issue you're on, one of the biggest problems or areas of conflict is this issue about whether it's irremediable or not, and whether it's permanent or not. That's what that means, right?
Correct.
Okay, so in your view, no psychiatrist can ever render an opinion that says a mental disorder is permanent and be accurate. Is that fair to say based on what you've told us?
Well, I think anybody could offer an opinion, but whether that opinion would be solidly grounded in science, I think is a very dubious claim.
Okay, so I have to assume then, in your opinion, that any doctor that does say that is overreaching and not using evidence-based science informing their psychiatric opinion. Would that be fair?
I would say so, and I just would wish that my colleagues would have better data to act on if we're going to go forward.
Okay, thank you, doctor. So I was a lawyer for 20 years before I went into this profession, and I can tell you with absolute certainty that every single day in the province of Ontario, you have colleagues in court testifying in psychiatric cases that persons have permanent, irremediable medical disorders. So you're here today telling me that those people are all giving opinions that aren't valid.
I mean, I think they're dubious. If you look at the Canadian Mental Health Association, the American Psychiatric Association, the Expert Advisory Group, I mean, numerous organizations have clearly said that in fact we can't make such determinations. And as I'll let Dr. Freeland obviously comment on her end, but the CPA has essentially taken no position on that. So the consensus is certainly that there isn't very good evidence for that at all.
Okay, so you agree then that there's a whole group of doctors out there giving opinions that aren't valid. Then that's your view.
Well, here's the issue. If someone asks, I mean, you can ask my opinion. Courts can ask people opinions. If we're asked, we have to provide the best opinion possible. But to make such a consequential decision, I would want better evidence, and usually in medicine you demand that.
You're not comfortable with it, but I don't think it's fair for you to sit here and say the entire profession is incapable of doing that. I'm going to pose that question to the other two panelists, see what their view is on that, because it seems to me anybody who says that a psychiatrist or somebody in that aspect of the medical profession can't do it is not necessarily giving the profession its due respect. Dr. Freeland, what do you think of that?
Thank you, Mr. Maloney. I think, so speaking from a CPA perspective, I think the perspective from the CPA is that we are trained in a certain way. We are committed to our profession. We follow through on doing assessments and treatment with patients, absolutely to the best of our professional ability. I think we all recognize that from an evidence-based perspective, there are clinical guidelines, there are practices and standards that we follow. But for many illnesses, when those things haven't worked, there is kind of an unknown that we all operate within. And the real importance of working in this area is about finding the balance between a psychiatrist's commitment to provide treatment, care, and hope for recovery, but really listening to the person's own experience of suffering and the right to make a personal choice in their healthcare decisions. And I think when we talk about science, there's the scientific part of that, but we also talk about the importance of the art of working with patients and reflecting that as well.
Thank you.
And I think that's what we've tried to do from a CPA perspective.
Thank you. I appreciate that. And Dr. Black, I don't have much time, so I'm going to go over to you. The last thing you said, that no personal opinion should form part of a doctor's view on when making an assessment, a view I share. I assume you said that because in your opinion that there are doctors out there who do have strong opinions on either side of this thing, and it does form part of their opinion. Is that accurate?
Absolutely. Very briefly.
Yeah, absolutely. Yes. I think it's a big problem. I think when we test the limits of psychiatric science, we have to both do that on the positive and negative. If we can't say for 100% certain what's going to happen, we also can't say that treatments will be 100% effective. This is why we put the patient at the core of our decision making. We give them the best information we can, and they make the best decision they can.
And that's ultimately what this is about. Thank you, Doctor.
Thank you. And next we'll have Monsieur Thériault for 5 minutes.
Merci, Madame la coprésidente.
Thank you, Madam Chair. My first question is for the 3 witnesses. Do you think that there is no mental disorder that is incurable under any circumstances? Who would like to start? Dr. Senior?
I'm not sure I fully understood. I think, or maybe I can just clarify. I think the issue is that our ability...
Considérez-vous qu'il n'y a aucun...
Do you feel that there is no mental disorder that is incurable under any circumstances?
No. I mean, I don't think that's what I'm saying. I think, there's a consensus that some mental disorders are incurable, and certainly that the suffering that exists as part of mental disorders might be incurable in certain instances, but we have absolutely no data to really identify what those instances are and how often they occur.
Dr. Freeland?
Dr. Black et ensuite Dr. Freeland.
Dr. Black, then Dr. Freeland.
So Dr. Black first and then followed by Dr. Freeland. Go ahead, Dr. Black.
In a previous meeting, Dr. Derek Smith sort of emphasized the importance of not focusing so much on a diagnosis, but the patient. And the patient's experience could very much be untreatable, incurable, and many of the treatments that we offer them may or may not work. Our ability to cure everybody is not 100%. Psychiatry has some good outcomes and some poor outcomes, and based off of different trajectories, we see various results. So I think it's very safe to say there are many psychiatric disorders that are not curable with present science.
Dr. Freeland?
I would just to underscore Dr. Black's comments and maybe to add that, common verbiage used in psychiatry is the concept of serious and persistent mental illness, which in and of itself speaks to the fact that we try and treat people, and there are many people that are left with residual symptoms and experience those symptoms in varying degrees of suffering.
Y a-t-il une forme d'acharnement thérapeutique?
Is there any kind of, do you think, are there heroic measures in psychiatric treatment? Dr. Freeland.
Again, speaking for the Canadian Psychiatric Association, we're founded on following evidence-based practice. We look at clinical practice guidelines. If I think about clinical practice guidelines, the concept of a heroic measure is probably not well articulated there. I do believe practitioners go above and beyond for patients and really think about what might be helpful for them. Despite that, there are people, as you've heard, that have outcomes that do not respond to a full complement of evidence-based interventions, in addition to maybe some other unique, innovative interventions.
Oui, vous voulez répondre, Dr. Senior?
Dr. Senior, can you answer?
Yes, thank you. So, I mean, I know that there has been some focus in this discussion on heroic measures, but I also think it's important as someone who is a practitioner in a tertiary care center that I've seen many people who have been judged to have irremediable illness in the community who are referred to our service and receive sort of higher level psychiatric treatments, neurostimulation, some of the older medications that we have, such as monoamine oxidase inhibitors. And we're actually, with not that great difficulty, able to essentially change their situation from being irremediable to remediable. And again, so that's the concern here, is that people will be inappropriately considered irremediable when in fact you don't need heroic measures, you just need really solid care to alleviate suffering.
Dr. Black?
Yeah, so just to follow up on that point, I think neurostimulation, older medications, these are all things that, I've practiced ECT and I've seen some pretty incredible responses. That being said, ECT is a daunting prospect for a patient that has a number of benefits and side effects. So do monoamine oxidase inhibitors. And so, again, it always comes down to the treatment may or may not be available. The question is it the right treatment for that patient? And patients have different reasons for saying yes or no to those treatments. I've also seen many people receive ECT, monoamine oxidase inhibitors, and many psychiatric medication combinations, and only experience side effects with no benefit.
Thank you very much. So we now have, to end off this first round, Monsieur Bouleris for 5 minutes.
Merci beaucoup, Madame la Présidente.
Thank you, Madam Chair. I'd like to ask Dr. Freeland a question. Earlier, you talked about socio-economic determinants that might put people in a position of mental health. You seem to think there's a link between socioeconomic problems and poverty and medical disorders. If there is action with respect to these socioeconomic problems, could this not help us avoid people's having to ask for medical assistance in dying for psychiatric issues?
Thank you for the question. As I understand it, the question is about if we spend more time focused on addressing socioeconomic determinants and their impact on people's experience of their health issues, would that avoid us having to take on MAID as a solution? I think part of thinking about treatment, and certainly again from a CPA perspective, the idea of biopsychosocial interventions to treat mental illness is really important and part of evidence-based care. So we think about assessing and treating the biological symptoms of illness using a variety of measures and treatments, but in addition, thinking about psychological measures and considering the social circumstances in which somebody lives. So when somebody has appropriate access to a treatment team that's able to provide biopsychosocial interventions, that should go a long way to try and ensure that we are providing people with the best kind of care, which is what we would all want to do in a situation with somebody who either has physical or mental health issues and is thinking about ending life because of the nature of their experiences. So as I said, one of the first and primary safeguards is to ensure that people have the right access to treatment. That being said, there may still be circumstances where somebody has experienced something in their life, or they are in a unique circumstance where, regardless of what a treatment team can do, it doesn't specifically meet that patient's individual needs. And so if that is considered to be the only way to try and mitigate MAID, I don't believe that that's something that will happen. And I think that's why, we have to think about those things in a very fulsome way and understand that as part of safeguards and do the best we can to help steer people in a direction of hope and recovery. And then think about what are the safeguards in place that we need to ensure people are not going too quickly to explore MAID as an option.
Merci beaucoup, Madame Freeland. Je pose une question.
Thank you, Dr. Freeland. I have a simple question, and if the three of you could answer, that would be great. On several occasions in our discussions, we've asked if experts can distinguish between unacceptable suffering and a severe psychiatric disorder or suicidal patient. Can you say whether someone is in a suicidal state or whether someone is in intolerable suffering from a scientific point of view. Dr. Freeland, please.
I think those are issues that we want to continue to understand and explore. As trained psychiatrists, we do get experience in how to tease those things apart. So to understand socioeconomic suffering versus the experience of having suicidal ideation as a symptom of illness. And so very careful assessment, using a fulsome team, seeking second opinion where needed is important for us to try and understand and tease those things out. And where that's applicable to the issue of medical assistance in dying, I think, thinking about the appropriateness of new curricula that helps train psychiatrists to think very specifically in this area, how to appropriately assess and be able to sort those things through will be important going forward.
Dr. So I would answer that we can all try. I mean, as you know, we're all experts. We can do our best, but it's never been the subject of rigorous scientific study. No.
Just simply answer yes and unequivocally yes. This is the core part of psychiatric training, and it's frustrating. Like, I understand the need for good scientific analysis, but there's many reasons why the science in this area is difficult to conduct. All the best science we have points towards a very clear difference between the type of suffering that happens in MAID requests and the general suicidal patient who presents to a hospital or to a psychiatric clinic.
Thank you very much. Thank you to all of our witnesses. We're going to the round with senators. I will turn this over to Monsieur Garneau.
Thank you, Senator. We'll start with Senator Mégy. Given that one of the senators will not be in this, I'll give the first three senators 4 minutes each. Sénatrice Mégy, vous avez 4 minutes.
Mr. Co-Chair, Senator Delphone is present, so there are 5 of us here.
He was referring to me. I'm going to forfeit my time.
Oh, I see. Okay, sorry about that.
Thank you. So, Sénatrice Mégy, vous avez...
Senator Mégy, you have 4 minutes. Thank you. Thank you, Chair. My question is for the 3 witnesses, for whomever wants to answer. One of the witnesses from our first panel talked about an increase in the suicide rate in countries where MAID is authorized. How can you explain this particular piece of information, and how people who have, there are people who have died because they have suicidal ideation?
Dr. Freeland, followed by Mr. Senior, followed by Dr. Black,
okay.
if you wish to respond.
Thank you very much. I actually will maybe skip this question because from a CPA perspective, we haven't specifically studied that, and I don't feel I can give a representative response. My apologies.
Thank you. Mr. Senior?
I would say that I've seen both argued, and frankly, it's another area where people are often just looking at curves without actual statistical analyses, sort of accounting for other factors that may affect suicide rates. But certainly, I think you have to be concerned about an increase in suicide rates in the context of MAID, because, as I said, that's my major expertise in research is around public messaging. And when you share with the public the idea that death is an appropriate response to mental suffering, you see more suicides. And so that's one of the things that the government of Canada certainly needs to grapple with if that's the message that is being sent.
Thank you. Dr. Black, do you wish to comment?
Yes, I have done these analyses. I've actually submitted the evidence to the committee. There's no evidence to support the notion that suicide rates have increased in countries that have adopted MAID, nor in states that have adopted MAID. And I've submitted that evidence to the committee. It's a positive claim, and it would require some pretty significant evidence. And it's absolutely true. It's fraught to compare countries in the best of times. When you're looking at curves and looking at things, what I would say is the rates are generally parallel to countries that didn't in their neighboring states and countries. So there's no notion to support that whatsoever that I'm aware of.
Merci.
Merci, Sénatrice Mégy.
Thank you, Senator Mégy.
Senator Kutcher, you have 4 minutes.
Thank you very much, Mr. Chair. Question for Dr. Black and then to Dr. Freeland. Let's follow the suicide rate discussion. Since Bill C-14 came into Canadian play, there's been lots and lots of public discussion about MAID in the media all over the place in Canada. What has happened to suicide rates in Canada since MAID was introduced, generally and specifically to the population, those over 50 or so that would more generally seek MAID?
Thank you for the question. I've provided that evidence in my brief to the committee. There has been no significant change to suicide rates since the implementation of MAID, despite many proclamations that it would increase by supposed experts prior to the passing of MAID. And it reminds me a lot of what happened during the initial phases of COVID, when a number of experts stepped forward and said that suicide rates would increase then as well. In fact, we've seen a significant decrease in suicide rates in 2020. There's been no impact in a negative way on unassisted suicides since the introduction of MAID.
So would it be safe to say then that all this public messaging around MAID has not led to increased suicide?
I mean, there's so many factors that go into a nation's global rate. I would, whenever we look at a large population rate like the Canadian average, we're including a number of people with a number of different experiences. So I think that probably, again, I'm always careful to not make a positive claim where one doesn't exist. I would say that the evidence that an increase has occurred because of MAID messaging is not substantiated.
Thank you. Dr. Freeland, thank you very much for tackling this issue of who decides whether their suffering is intolerable. If I understand correctly, your perspective is that a competent person's own experience of suffering dictates what they choose to do. A psychiatrist needs to offer all options to the patient, but it's the person who decides, not the psychiatrist who decides what will happen if the person is competent. Now, there have been concerns raised that some psychiatrists will never accept that a patient's suffering is not remediable. In such a situation where the psychiatrist feels that the patient's suffering is not remediable and wants the patient to keep going and going and trying and trying and trying, and the patient says, look, enough is enough, how should the physician, the patient, what happens in that relationship and how should they proceed together?
I think in those kinds of challenging situations, and maybe I would just preface this by saying, ideally, these are shared decisions because the patient is listening to the psychiatrist's perspective and input, and really we are there to think about hope and recovery. But at the same time, we have to listen to the patient's perspective, a competent patient, and bringing their perspective from what they want as well, and coming up with a decision that forges a path forward for the patient that they find appropriate for them. Where a patient feels that they are not perhaps getting what they feel they might need from a practitioner, I think the solution would be similar to what patients do when they experience that in many different medical predicaments. And there are opportunities for reaching out, requesting a second opinion, and asking for a reevaluation, maybe coming to a shared decision around what next steps should be taken, and then maybe a second opinion. I think there are different alternatives, but ideally these are transparent, informed conversations between two people who care about somebody's outcome and treatment and care.
Thank you.
Thank you, and we'll go to Senator Dalphond pour 4 minutes.
Merci, Monsieur.
Senator Dalphond for 4 minutes. Thank you, Chair, and I'd like to thank our witnesses who greatly contribute to our reflection on this issue. I'm going to ask my questions of Dr. Freeland.
Has been quite interested by the issue of access to MAID for mental disorders, and yet you co-chair a committee, a working group on this. So can you tell us how many members there are in that committee? And did your subgroup study the report from the task force?
So we have, and I'm sorry, I'm just quickly counting them to give you the right number. 2, 3, 4, 6, 7. We have 12 people on our working group. we went through a pretty rigorous process to request people apply. And we had a number of our members who applied to be on this working group. That process happened a few years ago. And I will just say we have people with many differing perspectives on medical assistance in dying, which I think is truly representative of our membership at the CPA. And that's why we have focused our work on, if this is coming to fruition, what are the safeguards and how do we truly educate our membership around understanding what the issues are. Our group has an upcoming meeting. We have not had a chance yet to review the expert report. I've had a quick look at it. And so I won't be able to provide comments formally from the CPA about that, but we'll be happy to share those once we've had our meeting.
Well, please send us a copy of once your subgroup has met. In the meantime, could you tell us, based on your previous discussions and your understanding of the report, is that report missing on some issues? Or are there some issues that needed to be further studied?
I think overall, the expert committee report from my cursory reading, it does reflect, I think, some of the important considerations for safeguards. I think some of the things that have been mentioned in the report were also things that from our CPA discussion paper and input from our membership were areas of concern for psychiatry. And so those things seem to be captured. And in fact, one of the appendices does reflect some of the areas from CPA in a table that includes the Canadian Bar Association and the CMA. So I do think that that would be there in terms of feedback from the CPA from that perspective. I think one of the things just really to hone in on is the importance of a really national standardized approach to this. As we all know, for all things healthcare, when things get to a provincial level, there's so many differences around how stuff happens. And I think this is going to be a challenging and important area to demonstrate that from a safeguard perspective, we've established a very clear set of oversight rules and really managing and making sure that the steps that we've taken are the right steps to be taken. So perhaps that would be one area in the report really to hone in on from that perspective.
And do you think it's possible to have these national standards within the before the contemplated date of these provisions of MAID coming into effect?
I think the expert committee did very good, fast work. So that from my perspective was important and promising. And I think we're going into the summer. I think it will depend on people staying focused and wanting to get that work done by next February.
Thank you.
Thank you, Senator. We'll now go to Senator Martin for 3 minutes.
Thank you, and thank you to all of the witnesses. I think I'm just going to continue from where Senator Dalphon left off with Dr. Freeland and ask Dr. Senior and Dr. Black for your comments regarding the expert panel report. So Dr. Senior first.
Ultimately, with respect, I mean, I think it appears the expert panel has done their best to provide you with what they think is correct, and I think they're entitled to their opinion. My response is that at the outset of their report, they rejected the idea that we need to ensure that harms don't outweigh the benefits before going forward, and that just deeply concerns me. It's that's not what we do in medicine. We haven't done that, for example, with vaccines. We waited pretty much a whole year after the vaccine was available before administering it, making sure that it was safe, because that could have been a disaster if they had been unsafe. And so the question is, why not do that in this instance? So in that sense, I disagree with them.
Thank you, Dr. Black.
I think the report was excellent. I find that I read it and agreed with most of it. I found it was a pretty good summary of the expertise we currently have on the issue.
Okay, thank you to all of you once again for your comments and expertise. Back to you, Mr. Co-Chair.
Thank you very much. Thank you to all of the witnesses. We will be getting ready for our next session, but I wanted to thank you on behalf of all of the committee members for your expert testimony today, for being very candid with us, for your opening comments, but also answering our questions on what is a challenging file and one that we take very seriously. So your input as experts is very highly valued. Thank you very much for taking the time in your busy schedules to be with us today. And with that, we'll suspend this panel. As you know, members, we have to provide a bit of a break at this point for our interpreters and others. And so we will resume with testimony from Dr. Gupta at 4:30 this afternoon. Thank you all, and this meeting is temporarily suspended. Thank you.
now have a very special panel for 1.5 hours. In our next panel, we will have the chair of the expert panel on MAID and mental illness, Dr. Mona Gupta. She's, I'm not sure if there are others accompanying her, but I see her online. This panel will be 1.5 hours in length, and therefore the format will be slightly different than our usual format. Following Dr. Gupta's opening statement of 5 minutes, actually, I misspoke. We are going to be going back to our original sort of round of questions. We have never been able to get to round 2, as you know. So we'll be doing round 1 with MPs, senators, and then the second round that we have with 3 minutes for both Liberal, Conservative Liberal, and 2 minutes for Bloc Québécois and NDP. So we have never gotten to the second round, but because we have 1.5 hours, we'll be able to do the full order. So at this time, Dr. Gupta, we welcome you and your expertise that you will bring to the table, and you will have 5 minutes to address our committee. So the floor is yours.
Merci beaucoup, Madame la Présidente.
Thank you, Madam Chair. It's a pleasure for me to appear before you in the name of the group of experts for MAID that was created under Bill C7 and whose final report was tabled to Parliament on May 13th, 2022. I'm a psychiatrist and clinician scientist in psychiatry at the CHUM in Montreal. In my practice, I work in medical psychiatry, which is a subspecialty devoted to psychiatric care of the medically ill. I have been involved in cases of persons requesting MAID primarily as a psychiatric consultant and sometimes as an assessor. In this presentation, I will provide a brief overview of the reasoning behind the panel's recommendations. I can elaborate upon this reasoning in more detail during the discussion period as needed. A quick note on terms. Although our mandate used the expression mental illness, we choose to use the term mental disorder as this is standard terminology in medicine. So from here on in, I will use the expression mental disorder. Our mandate was to make recommendations for safeguards, protocols, and guidance for MAID requests made by people with mental disorders and not to debate on whether such persons should be permitted to have access to it. Nevertheless, we took the concerns seriously by those who are opposed to this practice. We took these concerns seriously. And by these concerns, I mean the ones that are mentioned in the report, for example, incurability of a medical condition, irreversibility of decline, capacity, suicidality, and vulnerability.
Took our work. Our first observation was that people with mental disorders are requesting and accessing MAID now. This group includes a range of requesters, from people whose mental disorder is stable, to those whose psychiatric and physical problems are active and together motivate the request for MAID, all the way to those whose requests are largely motivated by their mental disorder, but they happen to have another qualifying condition. These requesters may have long histories of suicidality, there may be questions about their decision-making capacity, and they may be in situations of structural vulnerability. A second related observation that the panel made is that there are people requesting and accessing MAID now whose medical conditions are difficult to assess with respect to incurability and irreversibility in decline. For example, some requesters with chronic pain. Based on these observations, the panel concluded that if there is no single characteristic or problem that attaches to all people with mental disorders and only people with mental disorders. Mental disorders is merely an imprecise proxy for these concerns. So if the hope is that by excluding people with mental disorders as a sole underlying medical condition from accessing MAID, we can avoid having to deal with these difficult issues, clinical experience with MAID shows us that this is not the case. We are already facing these problems in practice. That is why the panel's approach is to try to address these problems head on. When we looked carefully at the concerns raised about MAID for mental disorders, we found that they are clinical in nature, meaning that the difficulties arise when clinicians have to apply legal terms to MAID assessments. For example, interpreting the word incurability for a particular medical condition or assessing chronic suicidality. What seems to be required to address these concerns is greater elaboration about the applicability of the eligibility criteria and the best approaches to adopt in assessing specific challenging issues in clinical practice. And the panel has tried to provide this elaboration and specification in our recommendations. This process of elaborating and specifying has also allowed the panel to clarify that in order for a mental disorder to be a grievous and irremediable medical condition in the sense of the criminal code, it must be long-standing and the person must have had an extensive history of treatment and social supports. MAID is not intended for people in crisis or those who have not had access to health and social resources. And with that, I will stop and very glad to continue on in discussion with you.
Thank you very much, Dr. Gupta. We will begin round one. And for the first questioner, it will be Monsieur Arsenault. Sorry, I will begin with Mr. Cooper. Yes, I'm looking at the other list. So, Mr. Cooper, you have 5 minutes.
Very good. Thank you, Madam Co-Chair, and thank you, Dr. Gupta, for being here. And I note that on page 21 of your report, it says that a consensus-seeking approach was adopted during the panel's deliberations, and that the authors had reached a unanimity in the recommendations. But I would note that that's not entirely true, as there were 2 members of your panel that resigned. Isn't that correct?
Well, it's true in the sense that they were no longer members. So the authors of the report supported the report unanimously.
And can you elaborate on why those 2 members resigned or left the expert panel?
Sure. So my understanding is that the panel was selected and appointed by both ministers, and that they sought to ensure there were a range of views represented amongst the panel membership, including members who had publicly stated that they were opposed to the practice of MAID for mental disorders. And as we started working on the report and the recommendations, one member, despite her initial willingness to participate, given her public opposition, realized that she could not reconcile her personal position with the work of the panel, given its mandate. So that was one resignation that occurred in December. And the second resignation occurred at the end of the panel process, at the end of April. And actually, I don't have information about the specifics of why the person chose to resign, but they sent a letter saying that they were resigning their membership.
Thank you for that. Also at page 21 of the report, it confirms that there was no stakeholder or expert consultation. I recognize the report elaborates that there was some very limited consultation, but that is correct, is it not?
So our mandate was not to do consultation, but what we did have to do was try to go out and get some information that was not available otherwise in the public domain. So yes, and we elaborated on that in the report. You're correct.
And
sorry, if I may just interject,
yes.
There's a note for Dr. Gupta. Would you raise your microphone a little bit higher, please?
Sure.
For the interpreters.
Is that better? Ça va mieux?
Dr. Gupta, if you could raise it just between your nose and your upper lip, please. Thank you.
Okay. Je devrais pas boire. Okay.
Merci.
And I've paused your time, Mr. Cooper, so you may continue.
Thank you, Madam Co-Chair. So no stakeholder or expert consultation and no consultation with Indigenous communities. Is that correct?
So again, our mandate was not to do consultations through an expert panel, and the panel was appointed with the requisite expertise on the panel to do the work. That said, 3 members of the panel do identify as Indigenous, and therefore were able to guide us and had sensibilities that we were able to happily take advantage of in reflecting on those issues.
Would you concede that the absence of stakeholder and expert consultations, which I recognize was not part of the mandate, diminishes the weight that should be attached to the findings of a report? I mean, surely you would concede that that would be important in terms of coming up with recommendations.
Well, I don't know if concede is the right word. I mean, I think we were given a task to do as an expert panel. And as I said, I believe the panel was constituted with the requisite expertise amongst the membership. We did that task. Stakeholder consultation, I think, provides a different kind of information that is also valuable. And if the government wishes to pursue that and obtain that, I'm sure that will contribute valuable information as well.
Changing gears, are you aware of any study on the reliability of physicians predicting irremediability?
By reliability, do you mean that if a number of physicians assess the same patient, that they will come to the same decision?
Yes. And any really more broadly studies on predicting irremediability?
Okay, so studies about reliability, about assessments, and then studies about predictions.
Exactly.
Yeah, so I am not aware of studies about predicting irremediability. I mean, irremediability isn't a clinical term, it's a legal term. So that's one of the things that the panel tried to do, was give it some clinical flesh, if you will, and put it in terms that clinicians can understand. So I'm going to just modify your question slightly, if you'll let me, and say, are there studies about predicting, say, for example, treatment resistance? That's a term that would be more familiar in psychiatry, for example, amongst people with a certain condition who have had certain kinds of treatments. Well, we certainly, for example, when we do research on treatment resistance, we certainly identify subjects to enroll in those studies. So you could say, yes, the researchers, clinicians often, who recruit patients for those studies come to agreement on who are treatment-resistant patients and who are not.
Thank you. Next, we will have Monsieur Arsenault for 5 minutes.
Merci, Madame.
Thank you, Madam Co-Chair. Welcome, Mrs. Gupta. Can you hear me? Welcome, and thank you. As the representative of this report, thank you for sharing all of this information. The people that are before you today are members of parliament, senators, and ultimately legislators. We don't all share your psychiatric expertise. When we're talking about mental disorders as a basis for a request for MAID, we've heard contradictory arguments, but it seems that there is a consensus. We can identify someone who is in a suicidal state compared to someone who is not, even when people are suffering only from mental disorders. You can make that distinction? Well, it's interesting. As you've heard before from other testimonies, there is a debate. So is wanting medical aid in dying the same as being suicidal? So the report made note of this difference in the scientific literature. So I'm just taking a quick departure as my role as the president of this group, and I'm talking about my own research. I wouldn't approach the matter from this standpoint of, like, can we distinguish these 2 points? But can we act when someone has a suicidal risk or not? And now I turn to other areas of medicine. For example, some patients will choose to cease treatment, and in such, lead to the end of their lives? Do we say that they're suicidal and then hospitalize them against their will and then force them to receive treatment? In some cases, yes. In some cases, no. So what are the practices that we use to make these decisions? So if I come back into my role as the president of this panel, we use these processes to reflect about a person who's asking for MAID. Should I act against their will? Or is this about evaluating their aptitude to make a decision? This is interesting because it brings me back to this question of irremediability. Psychiatrists in this field say it's not possible to define what is irremediable in psychiatric disorders. But earlier you were saying that medical assistance in dying could be considered for someone who has mental disorders that has been suffering for a long time and that has received all of the possible help. I'll now talk about the Supreme Court Carter decision. It says when a case is irremediable, it doesn't mean that the patient should receive treatments that they deem unacceptable. And for me, as a lawyer, I wonder, how do we join this Supreme Court recommendation and the opinion of psychiatrists? There were many layers to your comment and question. I'll try to respond as best I can. So one, the position of the panel is the word irremediable is not a clinical term. It's in the criminal code, and it's defined by 3 sub-criteria. So incurable, which sounds clinical. There's advanced and irreversible decline, and then there's suffering. So we can try and understand these words and define them for clinicians and decide how we interpret them in practice and what treatment goes for patients. I think a large part of the debate between those who say that a disease is irremediable and some people say it's not is that we're using different definition. This is why in the report, the group tried to propose a definition of incurable disease in the context of mental illness or mental disorder that makes sense. Of course, there are illnesses that we know can never be cured. We have 100% certainty, but there are other diseases whose evolution is not as well understood. So how much certainty do we have in the long term, and how much certainty do we need? And that's where the devil's in the details. Overall, we tried to say this. If we have to think about what incurable means and we draw a parallel with other chronic illnesses, it's that once you've gotten to the end of standard treatment, then we get to your comment about the Carter decision. Like Dr. Marr said earlier, we're not going to force people to do things that they deem unacceptable if they are capable of making this decision. If someone has an incurable disease, how do we treat them if they haven't tried every option? So this is something that is dealt with the negotiation between the clinician and the patient. Thank you. Thank you.
5 minutes for Monsieur Thériault.
Mr. Thériault, 5 minutes. Thank you, Madam Co-Chair. Thank you, Dr. Gupta, for being with us. I read the report on multiple occasions with great interest. My first concern is this. I thought it would be part of the mandate. And why is it not there? Why is there not this question of eligibility for mental disorders and mental illnesses? So I understand that you've addressed the issue of how to go about it, but if you can give us a short answer, why? Were you not surprised not to have this mandate? Well, I can give you a very short response. I think this is a question you need to ask the government because they are the ones that handed us the mandate. I think it's because it's already planned for in Bill C7, started March 23. So the revision was to see whether or not we would apply the sunset clause or not. I think it would have been interesting to have this discussion and to hear from experts about it. In this situation, Quebec doesn't want to move forward. And if it did, we would have issues with the application in the field. To establish whether something is incurable or not, we say that there are 3 criteria. Is the disorder chronic? We have to assess how much treatment was attempted prior. And then there's also the issue of refusal of treatment. We have to assess whether treatment refusal was repeated. Some people say that there are no incurable mental disorders. Of course, this is not what you're saying, but refusing treatment is a right that all patients have. What role does this play in your assessment of incurability? A patient that refuses treatment could be considered to not be doing everything they need to get treated. Does this preclude a patient from accessing medical assistance in dying? There are certain mental illnesses that are incurable, and they also cause some suffering. Thank you for the question. I'm going to take a small digression into a technical clinical area. There are some illnesses that are, like, for example, advanced stage cancer, where we have a biopsy. We know already what will happen. But there are other illnesses that at the moment of the diagnosis, we don't know what the outcome will be. It depends on the treatment that is chosen, the response to the treatment, etc. So it's difficult to predict the outcome of certain diseases without trying treatment. That's why in the report, we're trying to find a balance between trying treatments to establish the trajectory of the illness, while respecting that at a certain point, a person might have already gone through a lot of treatment and wants to give up. So where is that line? That line moves from person to person. We also have to take into consideration a patient's general health. Let's talk about assessment processes. I have a feasibility concern. Some psychiatrists are assessors and administrators of MAID. Some family doctors are trained for performing MAID in Quebec. But I know that some are very much opposed to MAID for mental illness. So you're saying that a physician needs to be an expert in a given condition, and the assessor should be a psychiatrist who is an expert in a given issue, but we already have issues with accessing psychiatrists in Quebec. Inaudible. Will we be ready by March 17th, 2023?
Okay, je vais juste peut-être.
Well, I can respond quickly now, and we can pick this up later. I think it's doable. Currently, when someone makes a request and they are suffering from a complex illness, we bring together specialists to get their opinion. I have an example that's not quite the same, but we can draw a parallel. When we have to make assessments, we need 2 psychiatrists, regardless of whether it's the evening or the weekend or whatnot, we make it work. These patients are the sickest and the most vulnerable, and so we can build a structure that will support these requests.
Okay, thank you, Dr. Gupta. Next, we will have Mr. McGregor to finish off this first round.
Thank you very much, Madam Co-Chair. Dr. Gupta, thank you so very much for joining our committee today and helping guide us through some very, very difficult issues. And I appreciate the report that we now have to refer to as we commence our study. I guess, for my first question, I've been a member of Parliament since 2015 now. I was there for the C14 and the C7 debates. And for me, the problem with this whole process is it seems like with the amendments that were made by the Senate to C7, which effectively are going to allow for mental health or mental illness as an underlying condition by March of next year, it's almost like a situation where we've put the cart before the horse, because we're involved in this very in-depth study, but we're working with an impending deadline that is now less than a year away. And you've talked a lot about the fact that we need to make sure every option is available. Before I get to supplementary questions, though, I guess my first question to you is, what was it like for the expert review panel working under the knowledge that you had this deadline, right? Did you feel a sense of pressure that how did that inform your work, knowing that in March of next year, this is now going to be a part of the criminal code and allowed?
Yeah, thanks so much for the question. And I appreciate the opportunity to have a chance to discuss these issues with you. I think it was Dr. Wiebe actually earlier today who talked about the commonality between chronic physical conditions and chronic psychiatric conditions. So I think I would start my answer there by saying that it was not so much the March 2023 legislative deadline that put pressure, because I think that we see a lot more commonality between psychiatric disorders and physical disorders, as I said in my opening remarks, which are already being structured under the Track 2 safeguards. So our task was really to say, well, let's take a look at these safeguards. Are they doing the work that we want them to do in situations of mental disorder as a sole underlying medical condition? I think the pressure is about wanting to respond in good faith to the concerns that have been raised, that we also shared and took seriously, and produce something that would work for patients, for families, for practitioners, and not just specialists in cities, but people who are living in rural or remote areas where access may be very different than it is in cities, for people living in all kinds of circumstances. So I think it was inherent to the exercise. That was the pressure.
Thank you for that. In your interventions with some of my other colleagues around this committee, you were talking about, we really have to make sure we have resources in there so that patients can avail themselves of every option for treatment. And certainly in previous testimony, we've heard of, quote unquote, groundbreaking research that's going on with psilocybin as a potential therapeutic intervention to help guide people through mental health problems. I know it's still in its infancy. I guess the issue for me is, and I realize that future patients who are accessing MAID, there will be the safeguards in place. They will have to have, an extensive history. I guess my concern is that I look around in my own community and I see so many people who are living on the street in obvious mental distress. And I keep wondering, if they had early interventions, could that have prevented them from getting to a state where it became so bad that they didn't see a way of pulling that out? I know the government of Canada has made some commitments to a big mental health strategy, but can you maybe just talk a little bit about just how much more is needed to really fill in the gaps? I mean, the last 2 years especially have really, I think, highlighted this issue in many communities like mine.
Yeah, that's a really good and big question. And I want to start by saying that I'm by no means an expert in the administration of mental health services, the financing of mental health services. I think just to connect your question to the topic that we're addressing today, I think we want to be thoughtful about the fact that mental disorders is not a homogeneous group of people. So I think there are subgroups. And I think that quite often, actually, in the public and policy debate about MAID, we conflate people with severe conditions who have been ill for decades, who have had a lot of treatment, a lot of follow-up, with people who can't get access to first-line resources during times of distress or times of personal difficulty, or perhaps at the beginning of a condition when actually they're not that severely unwell. So I don't think that responds fully to what you're saying, but I think thinking about what's needed to fill the gaps has to think about these different subgroups, because I think their service needs are quite different. And I know it's not popular to say, but I'm going to say it anyway. I think that there are patients in Canada that get excellent care. I'm sure that Dr. Senior's patients at a tertiary level center in Toronto, Dr. Marr's patients get excellent care. So I think part of the problem is sort of honing in on where the deficiencies are and recognizing that actually it's probably not just a big mental health strategy with a big spend that's needed, but really targeted funding for very different kinds of services for different subgroups.
Thank you, Dr. Gupta. I'll now pass this over to our co-chair, Mr. Garneau.
Thank you, Senator Martin. And we're now going to do a senator round, each 3 minutes. Just before I do it, Dr. Gupta, your microphone has slipped down a little bit. It causes popping. So just to minimize that, I know it's hard to keep in the same place. If you could lift it up a couple of inches, that'd be great. And we'll start off with Senator Mégy. Sénatrice Mégy, vous avez 3 minutes.
You have 3 minutes, Senator Mégy. Thank you, Mr. Chair. Thank you, Mrs. Gupta, for being with us today. I was looking at your recommendations. Number 16 on prospective surveillance, 18 on data collection, and 17 on periodic research. How do you see the federal government being organized? Should we have committees for data collection and surveillance, and then would we have a second one for that? Like, how would we organize it? Thank you for the question. There are many ways of proceeding. Research could be centralized within the 3 research councils at the federal level. They could issue calls for free projects or for targeted subjects. There could be research done on data collection that's already been done by Health Canada, and then the proposal we make in the report for new variables could be integrated within the monitoring system. The idea of attaching data collection is done in the Netherlands. In Canada, we have a system of having a call for projects, either open subject or targeted subject. There are many ways of proceeding, but the prospective monitoring program is something that can be considered, but it falls under provincial jurisdiction. For the moment, the federal government can play a coordinating role. The federal government can make sure that there are systems that would help the provinces have prospective monitoring systems. I would note also that psychiatrists are calling for this. They're asking for this to do their work well, to have an outside view on what they're doing, to make sure that they proceeded with the assessments correctly, given the complexity of the cases. Thank you. Do I still have any time? 45 seconds. I would like a last piece of advice or comment from Dr. Gupta. Following all of this work that you presided over, do you have one last bit of advice or comment to share? I would love to be able to call a friend like they do on that game show. Can I think about this and get back to you? Of course, no problem. Excellent.
Senator Kutcher for 3 minutes.
Thank you very much, Chair, and thank you, Dr. Gupta, for your thoughtful and well-considered testimony. I noticed in the report that you've made suggestions that will not only provide solid safeguards for individuals seeking MAID for solely mental illness, but also for all people seeking MAID. So do you think that your report actually would make a substantive contribution to the practice of MAID in general in Canada?
Look, thank you for the question. We were mindful of the fact that it wasn't our place to take on many different new mandates. At the same time, and as I tried to present in my opening remarks, our analysis took us there because the things that people are worried about in the practice of MAID are not unique to mental disorders. So we were a bit stuck and said, well, these things are really important, but they're not just important for people with mental disorders. These recommendations, they're important anytime you're concerned about the incurability of a condition. You know, this is an approach. Anytime you're concerned about suicidality, here's an approach and a way to think about it. So I hope so. I hope that our recommendations will be considered to be useful in track 2 and even in track 1. Suicidality exists in track 1 as well. Questions about capacity exist in track 1 as well. So thank you for the question. And yes, that is our hope as a panel.
Thank you for that. Now, specifically, it's fascinating that Senator Meji, who's also a physician, honed in on the same 3 things that I'm going to ask you about right now. The National Framework for Protective Oversight, Framework for Case Review, and the importance of the Ministry of Health, adding the additional research components and that you had put into your report. I would imagine, would you agree that the Ministry of Health could actually start putting those in right now? Because and then the second, for the other 2, the protective oversight and the case review, do you think it would be feasible for the federal government to convene provincial territorial governments and the other appropriate stakeholders to start moving that ahead immediately?
I mean, I think the data collection and research are things that fall squarely within the competence of the federal government. You know, other governments as well can do those things, but the federal government is doing them now and can take on those recommendations if it wishes to. And as for case review and perspective, we recognize that this is something that has to be done in collaboration between the federal governments and the provincial and territorial. But yes, we'd like to see the federal government take a leadership role in exactly as you said, convening the relevant parties to work on that. And it might be that there are different ways of approaching case review and perspective oversight in different provinces. I don't think the panel has a view on whether they need to be exactly the same, but that the principles that we've articulated be put in place.
Great, thank you very much.
Thank you, Senator. Senator Delphon.
Merci, Monsieur le Coprésident.
Senator Delphon. Thank you, Dr. Gupta, for participating and for having overseen the committee that did such important work with this report. The Canadian Association of Psychiatrists suggested that if there's something to be improved in your report, it would be to add national standards that would apply to all psychiatrists because they'll be involved. They need at least experts involved, but also for the other assessors. But do you think it's possible to have guidelines, national guidelines that could be applied nationally by March 2023? That's a big question. As you know, healthcare services are provincial jurisdiction, so I don't think the federal government can make any decisions for the provinces. This applies to how they organize their medical assistance in dying or how practitioners practice throughout the country. That said, there's already an organization nationally that has taken a leadership role by developing many guideline documents. And this organization is leading the way with a project to establish best practices, guidelines, etc., that apply to medical assistance in dying. Currently, clinicians will turn to this type of organization and documents to understand how they should proceed on a day-to-day basis. So even if it was possible for the federal government to work with the provinces and to magically create a national system, I don't think that this is where clinicians need help or direction. It's more about what to do, how to assess XYZ, and this is already within the hands of national organization. I do think it's possible, but I think the delivery date for that document is this fall, and the work has already been started. Do you think that there is support from professional organizations to make sure that we have national standards? Because, as you know, there are already many national standards in other areas of medicine. You know, yes, I think that regulatory bodies have a special role to play. I'm thinking, for example, of the Collège des Médecins du Québec that has taken a leadership role in this field. And the beauty of the regulatory authority is that all clinicians have to be a member. And I understand that in other provinces, the roles may be different, but if at least there's an approval to training, it sends an important message to members that it's important to follow the guidelines and you can't just decide how to do it on your own. Thank you. Thank you, Senator.
Was it for me? Oh, okay. Dr. Gupta,
Well, it's not, doesn't matter that much. It was for Senator Wallen.
Oh, I see. I did not.
Perhaps I didn't say it clearly enough. Assuming Senator Wallen is still with us. I'm not hearing anything. Why don't you go ahead, Senator Martin?
Okay, thank you. Dr. Gupta, I'm also quite concerned about the consistent policies and standards for our country, at the same time being mindful of the differences between rural and urban Canada, and specific to the Indigenous peoples, Métis and Inuit. So there's the cultural differences. So I'm trying to understand how, with the March 23rd deadline, that we can prepare for all of these different groups and based on a consistent standard and policy. Would you speak a bit more about how we will achieve this?
Yeah, thank you. And that's an excellent question. You know, in recommending what we did with respect to consultation, we really took to heart the advice provided to us by our three members of Indigenous identity. And while they believe that there are many members of Indigenous communities who are supportive of MAID and you know, who as individuals either may wish in the future to access MAID or support their family members accessing MAID, they also recognize that it is important that these consultations occur and that this is something that they've been expecting, in fact, since MAID was first permitted, and that it ought to be made good on. You know, what are the best mechanisms to achieve that? Where we landed was that this is something that ought to happen at a provincial level with the collaboration, perhaps, and leadership of the federal government, but because the communities are very different. So to have a single kind of Indigenous consultation, pan-Canadian, wouldn't necessarily work or reflect the important differences and nuances between the many Indigenous communities that are out there. You know, whether it can be done in a way that would respect the March deadline, I think it's for those communities to express themselves on that.
So the question is, how do we do that? How do these communities find the resources to be able to do that? So in your report at page 35, it says, as a result of the creation of laws that provide access to MAID, concerns have been raised by Indigenous leaders and communities that it is easier for people in their communities to access a way to die than to access the resources they will need to live. You know, change and improvements on many of the, you know, the reserves and the First Nations communities is very challenging at best and very slow. So I'm really concerned about this deadline. So what would you say in response to this specific quote?
Yeah, I mean, I think that's something that we need to ask Indigenous leaders and Indigenous communities. You know, how it is exactly that they want to move forward with this. And I do believe that the Government of Canada is increasingly working together in partnership with these communities, recognizing on a variety of different subjects the leadership and the ability to make decisions for their own communities. So I think it's a very good question that ought to be discussed, and those communities ought to be engaged on it.
Thank you very much, Senator Martin. We'll now proceed with round two, which is a shorter round. This is with the MPs, and we'll start with Mr. Stephen Ellis. Mr. Ellis, you have 3 minutes.
Excuse me, Mr. Chair, Mr. Co-Chair, but Senator Wallen didn't have her turn. I don't know if we want to return to her or not, sir.
No, it's fine. I'm having such technical problems, so please go ahead.
Senator Wallen, happy to have you. I looked across all of the screen and I didn't see you, so I assumed you were gone. Would you like your 3 minutes?
No, go ahead, please.
Okay. Therefore, we'll catch you on the next one. MP Ellis, you have the microphone for 3 minutes.
Thank you, Mr. Co-Chair. Thank you, Dr. Gupta, for being here. A couple of things, just to paraphrase, I heard you say that the patients need to be assured of appropriate treatment and social supports. Certainly we know that at a time in Canada, there's realistic inabilities to access those. We've heard from multiple witnesses, and certainly I've been a family physician for 26 years, so I've heard that over and over. How would you characterize, in your mind, access to treatment and appropriate social supports for mental disorders in Canada at the current time?
Just to make sure that I understand your question, are you asking me, do I think people with mental disorders have appropriate access
to treatment and social supports? That's correct.
Social supports, yeah. So I'm going to again preface my question by saying my area of expertise is not sort of administration, service provision, and mental health. So I'm a bit going from my experience clinically and my work on this report and on this topic. So, I think it's highly variable. I think that there are groups that do not have quick and appropriate access. I see that every day in my practice, particularly in first line care, right? People waiting a long time for pretty simple things. I see people that have great access to kind of mid-level care, but when they need something subspecialty, it's difficult to get. And the opposite, right? Depends on where you live in the country, unfortunately. You see people that actually who are quite severely affected, and they actually have, that's a good thing, right? The system actually works sometimes, and those people actually have appropriate services that are at a level of intensity that is needed for the care of those folks. So I do think it's highly variable. Obviously, it's like all healthcare services. I think it's worse. Access is poorer the further you are away from urban centers. And I think in urban centers, you've got lots of providers, but there's like a discontinuity there that maybe is less obvious in rural areas. That's something I experienced when I did locums up north, that there was less provision, but it was actually more coherent. So, I think there's a lot of variability.
So, Dr. Gupta, you did talk about Indigenous communities having a variable amount of ideas around MAID, et cetera, and that they should be taken individually. Does that also mean then, going along with this line of reasoning, that rural communities who have different accesses perhaps should have different inputs on how MAID is performed or safeguarded in their communities as well?
Yeah, I have to assume that in each province with its different geography, east, west, north, south, right? And some are very long and some are this way, that, and with different regional characteristics, that there needs to be thought, like there are for all healthcare services, I would say, is what is the best way to deploy a service or a practice. And so I think I'm hesitating about the idea that all rural communities will have the same vision about how it should be done. So I'm thinking that at a level of provincial planning, working with different rural areas is going to be necessary in order to ensure that service provision is what they want it to be. So for example, I can imagine in some areas, the idea of doing kind of growing on what we've been doing during the pandemic and doing video consultation will be quite welcome. In other rural areas where actually getting there in person might not be so difficult, they might say, no, we actually want to have, like what I did up north, locums where people come in and we can see them in person. So I think that's going to be, again, quite variable depending on the region.
Thank you. We'll go to Dr. Fry now. Dr. Fry, you have 3 minutes.
Thank you very much, Chair. There are two questions I wanted to ask Dr. Gupta. Thank you for coming and taking this sort of basically yeoman's duty today to spend all of this time answering our questions. There are two things. During the course of our witnesses, we have heard something that kept recurring. People said you shouldn't look at establishing incurability based on looking backward at what people had been, what their treatments were, what their access was, etc. You should be looking forward at what is the next big cure, what is the next thing, and giving them that kind of hope before you offer MAID, to saying, oh, no, let's keep going and look forward to what we have to offer. So that's the first question. I'd like to hear a comment on that. And the second one is a point that you made in the report, and that basically a lot of people sort of with witnesses and in the hearings kind of tended to take suicide and mental health and conflate them. And you clearly said in your report that people do not have suicidal ideation purely because they have a mental health problem. In fact, the majority of people with mental problems don't express suicidal ideation. But the second piece is that a lot of people with suicidal ideation do not have a mental health problem. So basically, should we conflate those two? Should we see them as separate issues? Because you are making the point that they are separate issues.
Yes, thank you very much for those two questions. So I'll start with the second one first. I think that's absolutely right. I think that there's obviously an overlap between mental disorder and suicidality. It can be a symptom of a certain number of psychiatric diagnoses. It is associated with completed suicide, but it is also the case that there are people who are suicidal who do not have a psychiatric diagnosis. So they need to be understood as two separate things. And as I mentioned earlier, there was suicidality in track 1, right? I remember a case in which a man attempted to kill himself because of the severity of his chronic pain. He did not complete suicide, and he came back and asked for MAID. And so I think that case raised very similar questions. Oh, are we helping him kill himself, basically? And this was not a man with any kind of psychiatric history. So you're absolutely right. They should not be conflated, and suicidality should be treated as its own phenomenon, independent of mental disorder. Maybe the case a person has a mental disorder, but we should think about it. We should be just as concerned about suicide in the person who does not have a psychiatric diagnosis as we are in the case of the person who does. With respect to incurability, I'm going to come back to the sort of technical clinical point that I made earlier, which is that certain diagnoses, because of what we know about the trajectory of those conditions, the moment the person receives the diagnosis, we have a pretty good idea of how things are going to evolve. And we have a greater degree of certainty. Others, particularly what we call sort of chronic medical conditions, at the time the person is diagnosed, it's very difficult to know what's going to happen. So they have to try a bunch of things and see what impact that has on their condition. So when we translate that to the MAID situation, if somebody has a chronic condition, the only way we can sort of say something about the severity of their illness is to look back and say, well, what has this person done? And it is the case that some people try lots and lots and lots of things and don't get a significant degree of relief or an improvement in their quality of life. And happily, many do.
Merci beaucoup.
Thank you very much. We will now move on to Monsieur Thériault. Monsieur Thériault, you have 2 minutes.
Alors, Monsieur Thériault.
Monsieur Thériault, are you there? You have 2 minutes. My apologies. I didn't hear you. I think there was an interpreting issue. In reading the report, with all of the precautions that are coming out with every recommendation, I get the sense that very few people with mental health issues would have access. Given that the Quebec Commission that discussed eligibility or not did not arrive at this conclusion, the bill that was tabled yesterday completely excludes this eventuality. Given that there's a lack of social consensus, of social acceptability to MAID for people with mental illness, do you think that March 17th, 2023 is coming too soon? I would like to say two things. First, it's true that very few people will have access to MAID if we follow the recommendations. However, these recommendations are similar to countries that do allow this access, and it is very difficult to access because people need to have access to care. We want to reassure people that they have access to care and treatment. We want to reassure people that when they are at the end of a mental illness journey and they are deemed incurable, that they have this option. As for the exclusion and the idea of consensus or social acceptability, I hesitate because I'd like to say this. Sometimes what is socially acceptable is not the right thing to do. Homosexuality, for example, has not been socially acceptable for very long. Also, not long ago, driving while drunk was socially acceptable. So I think we can question this. I'm sorry. I'm so sorry. We've arrived at the end of the time. I'm sorry, Mr. Theriault, you'll have another opportunity. We're doing 2-minute rounds.
That was me, Mr. Co-Chair?
That's correct.
Okay, thank you. Dr. Gupta, in the conclusion of your report, it stated that this report is the beginning of a process, not the end. And you very clearly outlined that the part that the expert panel played, you played a very specific role. It was defined clearly by your terms of reference. I guess as we, as a parliamentary committee, take the baton, so to speak, and carry on with this study, we're grappling with a major role because we're ultimately going to make recommendations as well to the government, and we as legislators may ultimately play a role in debating a future bill on this. I guess, I don't have much time, so my question to you would be, do you have any advice for us, the things that we should be keeping in mind as we continue this study based on the experiences that you had being so deep in these issues before us?
Yeah, thanks a lot for the question. And I'm going to take advantage of the question to also answer Senator Mégy's question from earlier about kind of last advice. I mean, I think that I would be really critical about exceptionalizing mental disorders and treating mental disorder as a sole underlying medical condition as some entirely distinct reality from people with comorbid mental and physical disorders or people with other kinds of physical disorders. So I think that would be my advice, is that I think the clinical reality does not support that idea. And I think it's worth noting that in the small number of countries where this practice is permitted, there are no legislated safeguards that are specific to people with mental disorders as a sole underlying medical condition. That pretty much the reflection, I think, has landed where
legislation problem. Look at that.
Yes, sir. There was a technical issue with the interpreter's console. We're looking at it right now, sir.
Okay, so we'll just pause until that's resolved.
C'est rétabli, Monsieur le Président.
Très bien. Alors, Mr. Cooper, I have stopped your clock, but you can resume now.
Thank you, Mr. Co-Chair. Dr. Gupta, do you believe that it is an acceptable risk that persons suffering from mental health issues who could get better could prematurely end their lives? Is that an acceptable risk?
Yeah, I think you're asking about the very heart of MAID, right? And I think the question is, who should decide whether that's an acceptable risk? And I think in allowing MAID in our country, we've said that is a choice for that individual to make that request. So, and that's what we tried to say in the report. Look, we understand there's benefits and risks, but that is what this practice is all about. It's giving the individual that opportunity, given a bunch of conditions and the conditions of the law and so on.
So in short, the answer to my question is yes. You believe that it is acceptable that people could prematurely end their life?
I think it's acceptable for the individual to make that decision, yes.
And in your report at page 40, it is stated that it is difficult, if not impossible, for clinicians to make an accurate prediction about the future of an individual patient. So how do you square that with the statutory requirement? It seems to be logically inconsistent to say, on the one hand, it may be impossible to predict, and as you know, in order to satisfy irremediable, it must be established that the person is suffering from an incurable illness, is in an irreversible state of decline, and of course, is enduring intolerable suffering. So I'm having a real tough time squaring the two.
Yeah, no, thanks for bringing that up. And I think, now we're getting into, I think, the really interesting details of clinical practice, right? Because you're going to have folks where, yeah, it's you can't say anything. Maybe the person hasn't had adequate treatment, or what they've had, you can't figure out from the file, was their treatment optimized, et cetera, or they haven't had proper social supports. You just say, look, there's too much uncertainty here, right? I can't say anything useful about what's going to happen in this person's course of illness. I'm not going to find this person eligible. But then there's going to be other cases where, in fact, the person has had a very long course of treatment, decades of care, high quality care, and has reached an informed and capable choice that they want to access MAID. So I think those two kinds of clinical situations and everything in between, complicate the thing. And then we've spoke to that in the report.
And I'm sorry to interrupt, but
go ahead.
Based upon what criteria would a MAID assessor make such a determination? Because your report doesn't provide any criteria, any specific safeguards. It merely speaks of, on a case-by-case basis, that the physician and the doctor, the physician and the patient come to a determination on that question of irremediability.
Yeah, so the criteria are the criteria that we would use assessing the severity of any chronic condition. They're based on what the person has already had. And, that's what we do all the time when we have to make determinations, as we mentioned in the report, about long-term disability, for example, or in any other contexts where psychiatrists and other physicians, in fact, are asked to say something about the person's, say, access to benefits on the basis of being ill, et cetera, et cetera. So it's based on that same kind of approach.
Thank you. Mr. Maloney, you have 3 minutes.
Thank you, Mr. Co-Chair. Just quickly, Doctor, first of all, let me add my thanks to the long list of those who are grateful for everything that you've done, including being here today. I just want to pick up on something that Mr. Cooper had asked you. He did what lawyers sometimes do, is he loaded the question with the answer, and he used the word prematurely, and he was asking you thought it was an acceptable risk for people to prematurely end their lives. I think I just want to give you an opportunity to answer that question again, because your answer suggested to me that you were saying it's up to the individual, which is the point you were trying to emphasize, not the premature aspect of his question. Is that fair?
Yeah, that's fair. And I mean, I understood the question to mean before they would die of whatever they're going to die of if they lived their whole life. So in that sense, it's premature. But yes, it's up to the individual to make a decision on the basis of the totality of their medical circumstances, whether they have reached that point.
Okay, thank you. That's what I thought. I mean, by that definition of premature, you could apply it to many circumstances. I get that. Thank you. One of your recommendations, of course, is the training of assessors and providers. Do you think that this should be a mandatory component of medical school curriculum?
Yeah, that is a very good question. Let me think about that. I think probably that learning about assisted dying and end-of-life care more generally should be mandatory, because I think it's something that practically every clinician is going to encounter. It's still a minority of people who are providing and assessing patients for MAID. So I don't know if medical school is the place where it ought to be mandatory, but perhaps later on in training, when people are developing what their future practice is going to look like, I think that's where something that's mandatory ought to happen. And I do think the idea of training that's very focused on MAID assessment and provision is a worthwhile idea. I don't think it's just enough to kind of learn about the law and then sort of hope that practitioners can figure it out.
Yeah, learning about the law is not going to help doctors in practical application, in my view. So the answer, I'll take it as a partially yes, but maybe the focus should be on continuing education and residency programs, perhaps. Is that a better place to
I think so. Yeah. Medical, it's such a competition in medical school curriculums to cram everything into the heads of these poor students in a very short period of time, that I think you want to gear training when people are, sort of making career choices.
Okay, thank you. I think I'm virtually out of time, so I'll stop there. Thank you, Mr. Co-Chair.
Thank you, Mr. Maloney. We'll now go
We'll now go to Mr. Thériault. You have 2 minutes. I think we'll be able to pick up where we left off. Indeed, I interrupted you because it's not about social acceptability that I was talking. My main argument was about the deadline. It was March 17th, 2023. Some people have not been trained yet, and we're talking about something new. There's a whole territory that said we asked the question this preliminary question that your panel didn't ask, and as a legislator, we asked the question and then decided that the experts were divided. There was no broad consensus like in other areas. How do we make sure that this can be implemented practically in the field? Because there's no situation, there's nothing clear about this. The National Assembly spoke against this as a whole. That's my main argument. I think your report is excellent insofar as it says we think that this can be done. Here are all the precautions we need to make. I think sometimes it's worth taking the time necessary to do things properly. Like I said at the start, it's important not to make exceptionalism for mental health. Currently, there are people with mental disorders that are a main component of their request, and I think that our assessors and providers are already doing this. I don't think that there's a huge lack of training between people who are already involved in the practice, because these are cases that they are seeing. And to continue on your comment about acceptability, I think that it's only if we say that some people say it's not acceptable makes this deadline too difficult. Perhaps consensus isn't the right thing to do, then all of a sudden the deadline is more acceptable. But the National Assembly is rejecting it as a whole. That's what's problematic. This is the conversation I want to have with you. Sometimes it's better to have a preliminary discussion, one that you didn't do, to take the time that is required to put something in place that works to make sure that there is some sort of consistency out on the field. Listen, I understand. You're in a sensitive position as a legislator at the federal level after Quebec has already made a decision. I wish you good luck. But I think, in fact, many studies had already been done. Lots of thought had been put into this. And there are things that appear to be contradictions, but by offering definitions and a way of understanding the issues related to this issue, will this be enough? I don't know. Thank you. I just wanted to add one thing. Like other professionals in Quebec, they're all in favor, so I was surprised, to be honest. I understand that before a divergence of opinion, the legislators didn't have much choice. Thank you very much. Mr. McGregor, you have the floor for 2 minutes.
Thank you, Mr. Co-Chair. Dr. Gupta, I think you were in the process during my last intervention of you wanted to provide an answer to Senator Meijy's previous question. If you'd like to take some time to get that on the record, you can go ahead.
Oh, sure. Thank you so much. I mean, my answer is actually not that long or complicated. My answer is simply that, so this was the question that she asked about kind of what is my final reflection after having done all this work. And I think I would say something like, I recognize that it's difficult and that these issues are complicated. And so we sort of have two choices. One is to say, this is too complicated, we're going to avoid it. And the other is to say, this is complicated, let's bring our best resources to bear on it, and let's try to come to ground. And that's what we did as a panel. There were plenty of divergent views on our panel, but let's try to come to ground on something that makes sense for patients and families. So I am confident that this group will continue to do its good work. And I hope, and my advice to you is that you not avoid the hard issues because they're hard.
Yeah, well, I think it's safe to say that with the subject matter before us, that it's impossible. It seems every meeting we're right into it. But yeah, I'll just close off with the time that I have to thank you again for joining us, and we do appreciate your testimony today. So thank you.
Thank you.
Thank you, Mr. McGregor. We'll now go to a round with the senators, 3 minutes each, and we'll begin with Senator Meijy. Vous avez 3 minutes.
Senator Meijy, you have 3 minutes. Thank you, Mr. Chair. I'd like to talk about patient autonomy. Respecting the patient's autonomy is the foundation of the decision that needs to be made when asking for MAID. When this autonomy is limited by various factors, either a lack of support, family support, or professional support or other, are there tools that healthcare professionals can access, specifically psychiatrists in this case, that would help them to assess the patient's autonomy in a precise way? Is your question about reduced autonomy or compromised autonomy? No, situations that might interfere with the patient's ability to choose. Well, the tools are the criteria for aptitude or mental fitness. We use the same criteria as Nova Scotia, the Applebaum criteria, that are complementary. So we use those. As you probably know, there's also a movement that was started by the United Nations to respect people's will even when they have a mental disability. This is something we talk about in the report, supported decision making. We didn't want to go too far into it because it's something that requires a lot more reflection. But I think there is a legislated reform in Quebec. There's already laws in British Columbia and Alberta, I believe. And we're putting in a structure for supported decision making for patients that have limited autonomy. That's the trend. It's part of a greater trend where we're not saying people are not mentally fit and therefore they have to do things that they don't necessarily want to do, or someone gets named to make decisions for them. So currently, we're trying not to take things too far. We see that there are legislative initiatives underway throughout the country, so we're watching that. Thank you. Thank you, Senator. We will now move on to Senator Kutcher.
Thank you very much, Mr. Chair. Dr. Gupta, earlier today we heard some inflammatory testimony that said MAID is actually a license to kill. In your report, you said that if there's uncertainty in either capacity assessment or suicidality, that the answer is no. You don't proceed with MAID. And it seems that your standards have actually been created to ensure that MAID is done in a thoughtful, comprehensive, and methodological way that puts the safety of the person at its core. Am I reading your report correctly?
I'm delighted that you read that, because yes, that is exactly what we were aiming for. Look, the folks that you heard from were all clinicians, we're all colleagues. We share those concerns, and none of us want to see a situation. No clinician takes pleasure in the idea that a patient would ever get to that stage, and no clinician wants to encourage a patient to give up hope in the possibility of being well or living better. So absolutely, we had those worries front of mind the entire time. How can we ensure that really the only people who have access are those who have really had a very significant history of disease and treatment, and have really been very thoughtful about this wish at this point in their lives. So that was our priority.
Well, thank you for that. We've also heard testimony that may have created confusion in our minds. And I've written this down because it's complicated. The testimony suggested that people who have been accepted for MAID for a mental illness, including those who are comorbid, so that is, they have a mental illness and a physical illness at the same time, but they're currently acceptable. The argument has been that they have not received substantial amounts of treatments, and therefore they should never be provided to individuals. Can you help us through this conundrum by being maybe clearly talking about what kind of treatment processes, what duration of illness, what kind of things actually would a MAID assessor have to look at? Not just for mental illness, but for comorbid mental illness, a mental illness and a physical illness at the same time?
Yeah, so I mean, it's highly variable, right? It's going to depend on the condition and the treatment options available and so on. But generally speaking, in psychiatry, mental disorders, whether there's a comorbid physical condition or not, it's almost irrelevant, really. They are treatments that require a lot of time. They require a lot of patience. They require a lot of follow-up care, a lot of changes. Even the very first medication you prescribe I mean, strictly speaking, according to the research, you wouldn't say treatment failure until 3 months had gone by. And that's the first one, not to mention the second, third, fourth, fifth, and then all the combinations that people try, and then all the neurostimulatory treatments that are accessible. So, when we talk about standard treatment, we're talking about really years of trials of different things. And that's the kind of treatment history that I think MAID assessors are looking for, whether it's a mental disorder, whether a chronic mental disorder, whether it's a chronic physical disorder. Quite frankly, in Crohn's disease, in epilepsy, in rheumatoid arthritis, you're looking at exactly the same kinds of things. What kinds of care has the person had? What kind of follow-up? What subspecialty opinions have they had? Have they had novel treatments, et cetera? So it's a very similar kind of thinking.
Thank you.
Thank you. Senator Dalphond.
Senator Dalphond. I'm not hearing anything. Senator Dalphond, we do not hear you.
Perhaps Senator just step out for a minute.
Peut-être que Sénateur Dalphond.
Senator Dalphond,
Je vois que
the Zoom meeting.
microphone does not seem to be working at this time. Sénateur, je vous suggère peut-être de.
Senator Dalphond is on mute.
Est-ce que vous m'entendez?
Ah, voilà.
Can you hear me? I had to plug and unplug. It seems like things are working. Go ahead. We seem to have lost him again.
Mr. Chair, Co-Chair.
Son image est gelée, Monsieur le.
Okay, so we'll just temporarily go to the next senator, and we'll come back to Senator Dalphond. Senator Wallen, if you're ready, you have 3 minutes.
Thank you very much, Chair. So my questions or comments are for Ms. Gupta, and I would just like to hear you express these. First, do you believe there is any real threat to a minority or a disabled community or a religious community or those with social constraints from the access to MAID legislation that exists? And my second question is this, and then you can judge your time. You have challenged us, all of us, to do the hard work. And I think that if we did not take up the complicated issues as legislatures, we know that in this country, we would not have Medicare or railways or a constitution or energy or food. So I know we need clarity for doctors and for citizens and patients. What is the most important thing that we must do as this committee?
Can I just clarify with respect to MAID for mental disorders?
Yes, and in the broader context, if you wish, please.
Okay. So with respect to the question of threat, I don't know. I don't know what's going to happen. I can't promise you that there isn't going to be some impact on some or the other group because that remains to be seen. That is not what we have learned from the countries that permit this practice. So to the extent that we can base ourselves on that, it seems like it's not very likely. Actually, it's a credit to communities that have raised these worries, the disability community in particular, I think, that have sensitized everyone in this debate to be mindful of their threats to well-being and to quality of life, and that MAID assessors and providers need to remember that and be sensitized to that and to take that into consideration. So actually, they need to keep going in their efforts to sensitize us to their lived reality. And I think that work has actually been invaluable. And you'll notice in the development of the CAMAP curriculum that actually that has led to the incorporation of people with lived experience, people with disabilities, et cetera, so that MAID assessors and providers are going to learn from their experiences. So that's, I think, that would be my answer to that. I think with respect to your second point, which is it's generous of you to ask for my opinion on that. I think the thing that has troubled me throughout the debate as I've been following it along is the sort of like strands of illogic or incoherence, right? That we can allow MAID for mental disorders when the person has a comorbid physical condition, like somehow that erases their vulnerability or erases their history of suicidality. Now they have a physical condition, it's okay, they can have access. But if that same person doesn't have the medical condition, oh my goodness, they must never have access under any circumstances. So there's an inherent illogic to me that I have never understood. And the fact that if somebody has a condition where it's really difficult to predict what's going to happen, they can have access as long as it's not a mental disorder. So this illogic is concerning to me, and I would encourage you to find a solution to this illogic. I think there are different ways of doing that, but it worries me because it suggests that as a society, we don't believe that people with mental disorders can really ever be capable of making their own decisions for themselves. And I think we've really fought hard against that for a long time. So I am surprised. And I absolutely understand the arguments about lack of resources. To me, it's not a choice that we have MAID or we have better resources. We need to be having better resources, period. But that's not a reason not to have MAID, I think.
Thank you.
I'll stop there.
Thank you, Dr. Gupta. Je vois que le sénateur
I see Senator Dalphond is back. Would you like your 3 minutes? Senator, please go ahead. Can you hear me?
You said that there's some uncertainties with some of the concepts, and that's why your group has come up with a list of recommendations that are, and you said these recommendations are based on what has been the experience in Belgium and the Netherlands. And based on that, you also refer to the fact that there's very few cases that are accepted. Most of them are turned down. So is it right to reassure people that are listening here that your recommendations are aiming at, in case of uncertainty, to lead to a denial of the requesters of the request, and therefore they're designed to protect and not to give, in case of doubt, the access to MAID, but rather to deny when there's a doubt?
Yes, Mr. Chair, you'll be very happy. My answer is very short. Yes, that is exactly what we're trying to say. Like in all aspects of clinical practice, if you have doubt about the indication of what you're about to do, you do not go forward.
So there's uncertainty with any words in the world. So, but what you're trying to is to guide the practitioners to remove that uncertainty. And if they still have uncertainty, they should say no.
Yeah, I mean, we're not going to remove all uncertainty, right? Medicine is largely a probabilistic discipline, and we're always making decisions under conditions of uncertainty. So there'll always be some uncertainty. The question is, how much is too much? And that is the line shifts, I think, with respect to that with time. But when there's too much uncertainty and the practitioners cannot come to ground on whether this condition should be considered incurable along the lines of what we've laid out, or the person does not have capacity, no, they should not go forward.
So the intent of your report is to err on the safe side than otherwise.
Yes, absolutely.
Thank you.
Thank you, Senator. We'll finish off now with Senator Martin. Senator Martin, you have 3 minutes.
Thank you. Well, what my colleague, Senator Dalphond, just said, to err on the safe side, I'm just going back to what Monsieur Thériault and you were discussing in your exchange, and the fact that March 23 is less than a year away. There are a lot of questions, and in fact, Ms. Abby Hoffman, when she appeared before our committee, said there hadn't been consultation with First Nations, Métis, and Aboriginal people. So I'm just wondering, with provinces, if they're not ready, will it fall upon individual practitioners to make decisions? I'm really quite concerned about the readiness of our country, province by territory. So would you comment on, I guess, anything to reassure me and others listening and members of this committee, because it is less than a year away, and we seem to not have this consistency and the standards across our country.
Well, I'll say, slightly tongue-in-cheek, that compared to the time frame of C14 and C7, this is loads and loads of time, whereas those changes happened very, very quickly. I think I want to come back to my opening remarks, which is we're already doing it. We're already evaluating requesters who have histories of suicide attempts. We're already evaluating requesters who have serious histories of mental disorder. So I'm not so concerned about the preparedness of the assessor and provider community. I think the training that's being developed is excellent. I think they should, practitioners should pursue it, but I'm not so worried about that. I think your question about consultation with Indigenous peoples is a good one. And as I said, I really think it's for Indigenous communities to say how they think we should move forward, and not sort of have a unified vision that gets imposed on them.
But well, I guess with that, who would lead those consultations? The federal government has not done that, so I don't see how individual nations or groups would lead their own and be able to understand what's happening federally, because it does involve the federal government.
Yeah, that's right. I mean, look, what our panel membership came to ground on was the idea that this could happen at a regional level. And you're absolutely right. This isn't something for individual Indigenous communities to organize, lead, and finance themselves. It's something that needs to be done in partnership between Indigenous communities and provincial and federal government. So my understanding is there are structures in place at the federal government level for consultation and engagement with Indigenous communities. And similarly, we encourage provincial authorities to do the same, particularly because we imagine there are going to be differences in the Indigenous communities across provinces, just as there are in non-Indigenous communities.
We haven't heard about what models there are for such consultation. Would you be able to provide our committee with the examples that you are citing?
Sure, yeah, I will. I believe that there, Crown and Indigenous Services has a framework for consultation and engagement. So I believe that exists at the federal government level. And no, I think at the provincial level, it was our hope that the regulators would take a leadership role in engaging with Indigenous communities within their provinces. So I don't think there's a specific model for that, but I can certainly forward you those documents that exist at the federal government level.
Thank you.
Thank you very much. And just before I thank you, Dr. Gupta, you do in fact have recommendation 14, which calls upon makes the recommendation of consultation with First Nations. So I think you've covered that as well in the report. Thank you very much for offering up your time this afternoon to face, I guess, a barrage of questions. It speaks to the fact that we are very engaged on this very important topic. We very much appreciate that you took the time to come and speak to us so eloquently about the work that you and your committee did. Thank you, and it will help us as we move forward. As you know, as you saw, we still have some questions, and that comes with our job. With that, committee members, we will suspend. We will now attend to committee business. As you know, it's a different link and password. So I will suspend for the moment and would ask you to reconnect with the different link in a minute or two. Thank you very much. This meeting is suspended.